Switch on your cameras. So, yes. So we can see a lot of people logged in. So please switch on your cameras if you're there. Okay. And for the people who have joined for the trial class, to introduce myself, Dr. Anita. I'll be doing obstetrics and gynecology and also psychiatry for the AMC Clinicals. Okay. So today we were doing obstetrics and gynecology. So this was one of the cases that was presented to me in the morning. And now we have a discussion left. So we'll start with the discussion of this topic and then we'll move on to the other cases. So when we come to other cases, we'll be doing the role plays and also I'll be giving them the feedback and then we'll have a discussion regarding the topics. Okay. All right. So this case, as Joe presented this case to me, I'll take you through this case now. So this is 56-year-old Jenny at your GP. She's on HRT for the last 6 years. So what's the new name for HRT? Anyone? Something It's also called MHT, menopausal hormone therapy. Okay. But usually we know it as HRT. So she's not having any menopausal symptoms at the moment. And she has come to you for a repeat HRT script. And she's not up to date with her mammogram and also HPV screen. So when you read through this, you know that she has been on HRT for quite some time now. Is it 6 years? And she's not having any menopausal symptoms at the moment. So the question that should go through your mind is, what's the reason why she wants a repeat script of HRT if she's not having any menopausal symptoms at the moment? Okay. So that's the first thing that you have to look for. And also, she's not up to date with her mammo and HPV screen. So, mammo and HPV screen are the community screenings for cancer. So the first thing that you should look for is, has she ever done this mammo and HPV screen? So if she had done it, what was the result? And the reason why she's not up to date with her mammo and CST. Okay, so HPV screen is cervical cancer screening test. And another thing that you have to look for is she having any symptoms of breast cancer, any symptoms of cervical cancer at the moment? So this is how your thinking should go during the 2 minutes time. Okay. So you know that we have 2 minutes outside the door to think about the case and read your tasks well. So first task is history, counsel the patient, discuss further investigations that you'll arrange for her with her. So, the further investigation, of course, she should be up to date with her mammo and CST. So you have to make her aware that she has to do the CST and mammo. Okay. So when you come to the history, so you ask her concerns to begin with. So she's here for a repeat script. So you tell her, I can see from my notes that you're not having any menopausal symptoms at the moment. So what is the reason behind the repeat script that you want? Okay. And she will tell you she feels more feminine when she takes the HRT. Okay. So that's the reason that she gives you. So you ask her why she was started on HRT on the first go. And she'll tell you she had all these menopausal symptoms that was interfering with her quality of life. So that is when the GP decided her on starting her on HRT. Also check on the type of HRT because we have 3 different types of HRT. So what are the different types of HRT that you know of? Anyone? Sorry?
Cyclical HRT.
Cyclical, yes. Then
continuous, cyclical, and estrogen only.
Continuous combined. Okay, so continuous combined and then estrogen only. Okay, so look at the type of HRT, which type she's on, and you also check on any menopausal symptoms that she is having at the moment. Okay, so she'll tell you no, because it's already given in the scenario that she's not having any menopausal symptoms. But look, after being started on HRT, is she regular with her follow-ups? When was her last follow-up? Any concern shared? Okay. But look for any risk of HRT so far. So you look for any pain in the calf muscles. And what is that question for?
EBT.
VTE. Stroke also is a risk for HRT. Then you also look for any chest pain palpitations, and that is for?
Heart disease.
That is for angina, okay. And also high blood pressure. And you also look for any history of cancers. So she's not having any risk of HRT so far. Then if she wants to continue on HRT, you have to look for contraindications. So all the risks are contraindications. At the same time, if she is having any active liver disease, that is again a contraindication because HRT is processed in the liver. Okay. So we check for that as well. And then you take a good menopausal history. Check on the age of menopause. So she had menopause when she was 50. Also look for any bleeding after menopause, which she doesn't have. Then go for the sexual history. So look whether she is sexually active at the moment with a stable partner. But you also look for any pain at the time of intercourse, any bleeding after intercourse. And what are these questions for? Why do you want to ask for pain after intercourse or bleeding after intercourse?
To allow the bleeding of the intercourse to allow the role of
PID maybe.
So that is mainly dyspareunia is mainly for atrophic vaginitis. Okay. So look whether she's having any atrophic vaginitis and postcoital bleed. It's a symptom of cervical cancer. So it's a cardinal symptom of cervical cancer, and you know that she is not up to date with her CST. Okay. So that is why you check on that. And also you look for any children that she has. And then you come to the reason for not being up to date with her mammogram CST. So she tells you, I don't think that there is a need to do this. Okay. So that is why she is not doing her mammo and CST in a proper way. So mark in your mind when you come to the counseling, you have to tell her why mammo as well as CST is important for her. Okay. So then advise her to go ahead with a mammo and CST. So we also check whether she had done her bowel cancer screening. So here she had done the bowel cancer. She has not done the bowel cancer screening also. So you look because she's not up to date with mammo or CST. You look, have you ever done these? And when was the last screen? So that was when she was 50. That is before she was started on HRT. Okay. Also look for any abnormal results at that time. So how often is a mammo done?
50 every 2 years.
Every 2 years. From?
50.
Can you do it early?
If first relative is positive.
If what is positive?
First relative, like
No, even otherwise, if they want to do it from 40, it is covered under Medicare. Okay, they can have it from 40 if they wish to do it from 40 years of age. Okay. So we also check for any abnormal results when she was screened with this, and also look whether she does any self-breast exam, because you have to look for any symptoms of breast cancer also. Any relevance why you'd want to do a breast cancer, why you want to check whether she is having any symptoms of breast cancer?
because she is taking HRT from 6 years.
So what?
There is a increased risk of breast.
Not contraindication. HRT can predispose to breast cancer. Okay. So that is why you check whether she does a self-breast exam, any breast lumps, any nipple discharge, any weight loss lumps or bumps around the body. So that's mainly for all the cancers. Okay. And then coming to the bladder, you just look for any incontinence because she is a postmenopausal lady. So look for leakage, other medical surgical conditions, medications, allergies. But because she is a postmenopausal lady, check on her lifestyle. So her diet is important, exercise is important, sad history is also important. And you also check for family history of cancers. So from the history so far, you know that she is not having any contraindications to be continued on HRT. At the same time, she is not having any indications to be continued on HRT as well. And she is not having any symptoms of breast cancer or cervical cancer at the moment. Okay. But that doesn't mean that she should not do the mammo or CST. Okay. So this is what you gather from the history. So when you come to the counseling, ask her if she knows about HRT, what it contains, and she will tell you yes. Okay. So in the counseling, what you have to focus on is mainly the risk of long-term HRT. Okay. So say that most of the guidelines recommend HRT for 5 years. So there are certain risks that if you continue taking it for more than 5 years, we normally study on HRT after analyzing the risk-benefit ratio and when the benefits clearly outweigh the risk. So we started on HRT by the age of 50 because you had all menopausal symptoms that was affecting your quality of life. Okay. So now when we analyze the risk-benefit ratio, it is risk that will be outweighing the benefits because you are not having any menopausal symptoms at the moment. Okay. So the risks are like you stand an increased chance of getting heart disease, stroke, clots in your leg vessels, and HRT can also increase the risk of breast cancer. So it's better to consider stopping HRT, but it's always your option. Okay. So if you think that you need it to improve your quality of life, you can think about continuing, but always you have to keep in mind the risks that are associated with the HRT. Okay. So if you do not wish to continue on HRT any longer, I can taper down the dose of HRT, bring it to a stop over the next 3 to 6 months. Okay. And then meanwhile, make sure that you follow a healthy lifestyle. So now comes a question from the role player. If I consider stopping it, what if the symptoms reappear? Okay. So you say that if the symptoms reappear, which is quite unlikely because you have been on HRT for these many years, I'll refer you to a specialist. So the specialist might consider restarting you on a low dose HRT, or they will give you any alternatives to HRT. What are the alternatives to HRT that can be given? Any alternatives? Anyone? SSRIs, SNRIs, okay. So we can also give gabapentin, pregabalin. Pregabalin is very much used here. So pregabalin, all these are like on non-hormonal alternatives to HRT, okay. So SSRIs, SNRIs, again, they can bring up the mood, but at the same time, it is seen that they can also reduce the vasomotor symptoms that is associated with menopause, but to a lesser extent when you compare to that of HRT. Okay. So the same with gabapentin, pregabalin. So you know that these are all mood stabilizers. And again, to a lesser extent, it can alleviate the vasomotor symptoms also. Okay. So those are the alternatives to HRT. So no need to say the alternatives, but I'm just making you aware of the non-hormonal options that you have for HRT. Any hormonal alternative for HRT?
Tibolone.
Tibolone, excellent, Saurav. So Tibolone is one of the hormonal alternatives to HRT, okay, which you don't consider here. So coming to the management, so your next task is to frame the investigation. So you have to do all her basic bloods. So you do her full blood exam, CRP, UEC, LFT, thyroid functions, her sugar levels, lipid profile, because she is 56. So you have to do a complete profile and you also do a vitamin D and a urine routine. Okay. So make her aware that cervical cancer screening test is done every 5 years to look for a virus called human papilloma virus once you're sexually active, because if you have this virus in the genital area, it can predispose you to cervical cancer. So that's the reason why we offer a community screening for cervical cancer like cervical cancer every 5 years. Okay. So it's better to do it so that you can prevent cervical cancer from happening. And as you know, cervical cancer has got a high mortality and morbidity rate. So if you're not happy with me doing the CST, you yourself can do a self-collection sampling and I'll advise you on that. Okay. So you make her aware that we have an option for self-screening also. Okay. So now coming to the mammo. So you say that that's especially because you're on HRT, there's a risk that HRT can increase the incidence of breast cancer. So it's better that you do a breast cancer screen or a mammogram. So even otherwise, we are offering a community screening for breast cancer every 2 years, because if we catch breast cancer at an early stage, we can do, like, it is quite treatable, and you can again decrease the mortality, morbidity associated with it. So you can arrange an appointment with the breast cancer screening lab ASAP and get it done before we decide on HRT. Okay. So that is how that also need to be addressed. So if she's not up to date with her bowel cancer screen, ask her to do that as well. And it can be repeated every 2 years. So you offer to see her with the test results. You can also give her printouts regarding HRT, the risk that is associated with HRT as well. Okay. So this is how you have to do this case of counseling for long-term HRT. Okay. Any questions that you have for this case? Long-term HRT? No questions? So I haven't seen this case this year, but it has come last year. Okay, so it's a last year's case. So far, it hasn't come this year. Okay. Any questions? No questions? All good? Okay. Okay. So if you have no questions, then we'll move on to the next case. So who will be doing the next one?
I'll do it.
Okay. Bhavna, Chrislyn, can you please put the role playlist in the chat box? Because we have the last Zoom link is gone. Yeah. All right. Bhavna, I'll give you the case. This is your case, Bhavna. Read through it. I'll time it 2 minutes. You were not there in the morning?
I was there, dog. I was online.
Oh, okay. All right. I didn't see you. That's why I asked. Yeah. Thanks, Chrislyn. Time me 2 minutes, okay, Bhavna?
Now it's starting to stress.
Who's at the center?
It's Rob, doc. He is here after his exam, so.
Oh, okay. You can start, Bhavna.
Hi, Anne. I'm Dr. Bhavna. I'll be taking care of you today. May I know how can I help you?
Look, doctor, I'm having these flashes and also I'm having these irregular periods. So I'm much bothered about the periods, So, and I'm getting worried about this, why this has been happening.
I can see it's irregular, so it can be worrying sometimes, but I'm here to help you. Don't worry. If it is okay with you, can I ask you some questions and then we can discuss how we can proceed with the management?
Sure, doctor.
Okay. So when was your last menstrual period?
Last menstrual period was 3 months back.
Okay. 3 months back. And is it before that it has been regular, or like how often do you get your periods?
Before 8 months, you're asking?
No, before 3 months.
Before 3 months, it has been irregular, doctor. I used to get it every 2 to 3 months.
Oh, okay. And what about before 8 months? Was it regular?
Yeah, it used to come every month.
Okay. And can I know how many days you usually have your menstrual bleed?
Now it is just 1 or 2 days that I have. Yeah.
And before 8 months?
Before 8 months, it was like 3 to 4.
Okay. And um, is it the periods you are having now, which is irregular? Is it a heavy bleed or a normal bleed?
I've noticed that it has become a bit scanty.
Okay. And do you notice any clots, or like how many pads do you use?
Now it is like 2 parts to begin with, and then it comes down to one.
Okay. Mm. So, as you are 50 years, are you sexually active?
Yes.
Okay. You have like before we proceed, like I want to tell you whatever we are, the conversation we are having will be confidential between you and me. So, do you have multiple partners or like single partner?
No, I'm with my husband, a stable partner.
Okay. And have you ever noticed any pain or bleed after intercourse?
No.
Okay. And do you practice safe sex?
What is that?
Like, do you use condoms?
My partner had vasectomy.
Oh, okay. The partner had vasectomy. Ever screened for STIs?
What is STI?
Sexually transmitted disease. Ever screened for that?
No.
Okay. Ever diagnosed with that?
No, I haven't been screened for it.
Oh, okay. Um, are you up to date with your mammograms?
Mammogram I haven't done. What is mammogram?
That is a scan done to check for your breast,
No,
if there is any cancer or not.
no, I haven't done it.
And any scans for bowel cancer or any other cancers, like, are you up to date with them?
I haven't started with the bowel cancer. No.
Oh, okay. And may I know, like, do you have any other symptoms, like any sweating or mood swings lately?
Yeah, I feel a bit irritable, and my partner is not happy with my mood swings.
Okay. And any sleep disturbances that you noticed?
Yeah, sleep is also not good.
Okay. And any muscle weakness or pain?
No,
Okay. And any dryness in your vagina that you noticed?
no.
Okay. Y- any weather preferences you have, like,
Don't look into your notes. Okay.
look, I'm just writing down
Writing down. Okay. All right.
positive.
Okay.
So, any weather preferences you have, like, feel cold,
No,
cold recently and all. Okay. And are you taking any contraceptions?
no, my partner has done vasectomy.
Oh, yeah, right. Sorry. Uh, and do you?
The 5 minutes is over. Okay, Bhavana. Yeah.
Okay. Can I
If you
continue?
want, you can continue with the
Okay.
history.
By any chance, do you smoke?
Never smoked.
Consume alcohol?
That's just occasional.
Okay. And any recreational drugs that
Abated drugs.
any past medical history that I may know of?
Like what, doctor?
Any heart conditions or high BP or any ever oh, you are not up to date with the cancer screens. So ever any loss of weight that you ever noticed?
No.
Okay. And any family history of cancers?
Nothing that I'm aware of.
Okay. Uh, yeah, that's it for the history. And from the positives, so from the positives that I got from the history, what I believe and that these are the usual symptoms of you reaching to your menopause, as you are already 50 years and like your cycle is becoming irregular. Uh, all these and having these mood swings and what else was positive? And the sleep disturbances, all these are the symptoms of like you are about to reach your menopause. And this is because the decrease in there is an hormone, estrogen, which help to regulate your cycle. And it is decreasing. So due to which your cycle is becoming
Why is it decreasing, doctor?
Because like by this age, I have to explain everything. Okay. So usually this hormone is to maintain your cycle and to maintain ovulation uh, whenever you are planning for birth. And like there are multiple roles for this hormone,
No,
but
I'm just asking why this estrogen is coming down.
uh, because you are reaching your menopause.
So why does the estrogen go low when I'm reaching menopause?
Uh, so that because there are the number of follicles are
It's okay, leave it. Come to the
okay.
next.
Thank you, doctor. And so to help you with your symptoms, what we can do is we can start you with hormone replacement therapy, which is a therapy in which we will give you these hormones, which is progesterone and estrogen, that will help you regulate your like these irregular cycles as
So if I start on this, my cycles will become regular?
it's not it will just it is just an kind of a supplement to help you with the loss that you are having with your like hormone estrogen.
No, doctor, just because I told you I'm much concerned about the irregularity of my periods. Do you think that if you start me on this, my periods will become regular?
Yes, it will be regular. I think so. It should be regular. I don't know.
Okay, it's okay. Come to your third task.
For I know that I have to start her on hormonal replacement therapy, but I
Come
don't
to your
know.
third task.
So the benefits are that it can help you like decrease the risk of it can decrease the risk of breast cancer. It can also decrease the risk of you getting osteoporosis, which is like bone disease, which usually people getting old are prone to get an disease of bones, which is osteoporosis. And it will also help you regulate your mood swings and all the positive symptoms that you are having at your menopause. And risks are, so from the previous case, I can recall of that the risk of HRT could be can be heart diseases, DVT, and it could be stroke. And that's all.
That's it? Okay, all right.
That's all.
Yeah, you took 3 minutes extra, Bhavna. Okay.
Okay.
Bhavna, to begin with, you took a good history regarding the periods. Okay, so you asked me regarding the irregularity of the periods since the last 8 months, and before 8 months, you had a comparison. That was very good. Okay, but you also look for any bleeding in between the periods, intermenstrual bleed. So then it came down, the case came down. Okay. So you have to look for, you asked me for other menopausal symptoms long way afterwards, but you have to, now you have to check for other menopausal symptoms. Okay. So like towards the end, once you finished your 5 minutes, you were asking me for sweating as well as mood swings and all those dryness of the vagina. But again, you can also look for any bone pain that she is having at the moment. Okay. And also any dysuria. Is it affecting her quality of life? So that's a very important question that you have to ask for. Okay. And sexual history, what was the main cancer that you missed upon, Bhavana? Cancer screening that you missed on?
Cervical cancer.
Cancer screening. So you missed on that altogether, is it? So that's the most important screening that you have to ask for. And when you came to differentials, I could just see that you were putting like thyroid differential, but there are other differentials also you have to frame. And if you're thinking in terms of HRT, the most important one that you have to cover is the contraindications for HRT. Okay. So you asked me for heart disease, high blood pressure, but again, there are a lot of other contraindications for HRT. Okay. So that's a critical key point in the history, whether you're covering the contraindications for HRT, if you have HRT in your mind. Okay. All right. So these were the things that was missing from the history. So make sure that you take the contraindications of HRT, and you took a long time for the history. Okay. Because you were just thinking and then asking. So it should come at like a flow. Okay.
Yeah.
So when you came to the condition, what is this called, Bhavana? So you just said that I'm reaching menopause. So what is this condition called? Anyone?
Premenopause.
Anyone?
Premenopause.
Perimenopause. This is what we call as perimenopause, is it? So that is the condition that, because I have specifically asked you, discuss with her condition. Okay. So you have to say that word is perimenopause that she is going through. And what is the reason behind perimenopause? You told me it's because of decreased estrogen. So usually the role player will put in a question, why does the estrogen become low? So just one answer. What is that? No need to say about follicles, no need to say about ovulation, nothing. Okay. What is one point that you can say there?
Ovaries start shutting down.
Ovaries shutting
Ovaries
down.
shut down completely,
So
yeah, and the
say
level
that
of
the
estrogen
ovaries
is
are
low.
shutting down. So that is the reason why the estrogen levels are going low. Okay. So when you came to the management plan, you told me that you would be starting me on HRT. But Bhavana, wouldn't you like to do the investigations before you start her on HRT? Wouldn't you like to look for all the contraindications? Okay. So that was very important. Management includes investigation and treatment. Is that? So first you have to arrange all the investigations. Which investigations are important for you, Bhavana, here?
Thyroid function test.
Good. Excellent. Yes. Then?
And all basic bloods are done. Then mammogram.
Yes, you do a mammogram as well. Yes, good.
Ultrasound.
Why do you want to do an ultrasound? Or which ultrasound will you do?
For bowel cancer and
Oh dear. Bowel cancer, why do you want to check? You're starting her on HRT, is that so? Why do you want to do an ultrasound here? Anyone, which ultrasound would you do?
Per vagina to check the uterus.
Transvaginal ultrasound. So why do you want to do a transvaginal ultrasound? Just a moment.
If there is any endometrial or fibroid.
Because she's having irregular periods, is it? So irregular periods can also be because of cancers, is it? So, and she is perimenopausal. So you have to look whether she is having any cancers, any endometrial hyperplasia, which again is a contraindication for HRT. Okay. So you have to check for all those. So first comes investigations and then you start her on HRT. Okay. So which HRT will you start her on? Anyone?
Cyclical and sequential, cyclical or sequential estrogen and progesterone.
So what is cyclical sequential HRT?
Cyclical is the starting of taking the menstrual cycle of 28 days. We'll start with estrogen and progesterone for the last 2 weeks. So after
Last
this
10
commencement
days,
of
10 to
progesterone,
12
it
days.
does
Okay.
withdrawal bleeding. Yeah.
So that is how you put her on cyclical HRT. Okay. And will her periods become regular if you put her on cyclical HRT? Anyone?
It should be.
Yes, cyclic.
How? So when you're saying something, you have to reason it out, etc. So you just can't say, okay. So if she asks you, will my periods become regular? Of course, it becomes regular, okay? Because you are giving progesterone in a cyclical way, is it? So when you withdraw the progesterone, she'll go in for a bleed. So that is how it becomes cyclical. Okay, so she gets her irregular periods will become regular. Okay. So, and she already told you that she is much worried about her irregular periods, is it? So it will become regular once you put her on cyclical HRT. When you came to the benefits, Bhavna, you told me it decreases breast cancer. HRT is a risk. Breast cancer is a risk for HRT, is it? Not decrease. Okay, so that's a huge error if you say that it will decrease breast cancer. So it's actually a risk that is associated with HRT. Okay. But benefits you told me, like osteoporosis, and also it will alleviate my symptoms. So there are some other risks also associated with HRT, okay, which you told me, like heart disease, stroke, okay. All right, but that breast cancer, it increases the risk of breast cancer, okay. So that is why we have to do a mammo before we start them on HRT, okay, right? Okay, keep going then.
Thank you.
Okay, Bhavna is a very happy person. That's what I think about her. Okay. Even if she doesn't do a case well, she's very happy. That should be the thing, Bhavna. Okay, be positive, be happy. Okay, all right. Okay,
Thank you,
keep going. Yeah, bye-bye. Okay, so I'll take you through this. So this is 50-year-old Anne, who is coming with hot flashes and irregular periods for the last 8 months. Her physical exam is all normal. Okay, so what does that mean for you? So maybe she's not having any organic causes behind the irregular periods and the flashes that she's having. Okay. And basic bloods has been done, a full blood exam, CRP, UEC, LFT, FBS. So all this has been done, which are all normal. Okay. But what is the investigation that is not covered under these investigations?
Thyroid function test.
Thyroid. And one more.
LHFS hormonal.
Sorry?
Hormonal, I think.
Hormones.
Which hormones?
LHFSH.
Why do you want to do LHFSH?
Because in menopause they will increase, I think.
Sorry?
In menopause they will increase, but on
Not menopause. When she is perimenopausal, there'll be a rise in LH and FSH. Okay. So that's why you have to do the LH FSH as well. Okay. So that is what you have to think about. And 50 years, is the age of perimenopause. Okay. So she might be having all these as a part of perimenopausal symptoms. But having said that, it's not only perimenopause that results in these sort of symptoms. So thyroid disturbances can also result in these sort of symptoms. Any other differentials that you'll think about for these flashes and irregular periods apart from thyroid and apart from perimenopause?
And maybe pheochromocytoma.
Which cytoma?
Pheochromocytoma.
So pheochromocytoma will cause flashes and irregularity of the periods?
No irregularity, but consider differential episodic at ARIMGSAS.
Irregularity of the periods can also be brought about by pheochromocytoma. Okay, not only flashes. Any other conditions that you'll think about?
Irregular period is hyperprolactinemia.
Which one?
Hyperprolactinemia.
Hyperprolactinemia, yes, then?
Stress or any kind of psychiatric history.
With psychiatric problem.
Yeah, anxiety.
Generalized anxiety disorders. Will it affect the periods?
Yes.
Stressors can affect the periods also. Okay. So all these are differentials that you have to think about. So it could be perimenopause or it could be thyroid disturbances, hyperprolactinemia, but hypoglycemic attacks can also bring about. Okay. So hypoglycemia, again, you can see that the periods will become irregular and also they will have these flashes and sweating. Pheochromocytoma, carcinoid syndrome, generalized anxiety disorder. So all these are conditions which can cause an irregularity of the periods as well as flashes, vasomotor symptoms as well. Okay. So when you go inside, ask her concern. So she's much bothered about the irregularity of the periods. Take a good period history. So the last menstrual period was 3 months ago. So what's the thing that will go through your mind now? To rule out a pregnancy, is it? So even though she's 50 years, still she's fertile. So if the last menstrual period has been delayed, always make sure that you do a UPT. Okay. So you also ask how often is she getting the period? So it's every 2 to 3 months. So number of days of bleed. So she had noticed that her bleed is a bit scanty. And you also look whether it is a heavy bleed, light bleed. So she's saying that it has become like scanty again, like a light bleed. Also look for any bleeding in between the periods, any clots, any pain. Okay. So have a comparison with the period history before 8 months. So then only you can get a correct picture regarding the alteration in the periods that she is having. So you ask before 8 months, how often did you get your period? So it was every month. And the number of bleeding days was 3 to 4. And also it was a normal flow. So now you can see when you compare this period history with the period history before 8 months, what is the condition that she is going in for? Less bleeding, less number of days of bleed. What will you think about?
Ovarian insufficiency.
Okay. Periods.
Oh.
Oligomenorrhea. This is what we call as oligomenorrhea. Okay. But oligomenorrhea can happen with perimenopause also. So it won't always be a menorrhagia that you get in perimenopause. So you can get oligomenorrhea also in perimenopause. Okay. So look for other symptoms. So other perimenopausal symptoms, sweating, mood swings, sleep disturbances. So here she is having sleep disturbances because she gets her flashes mainly at night. Okay. So you also look for any vague muscle aches and pains, any bone pain, vaginal dryness, soreness. Can also look for dysuria. Why dysuria? Why do you want to ask for dysuria?
UTI can be increased.
UTI.
Atrophic vaginitis.
Atrophic vaginitis will not result in dysuria. Atrophic urethritis, because the urethra is lining is also dependent on estrogen. Okay. So you also look whether it is affecting her quality of life. Go for a good sexual history. You look whether she's with a stable partner. But again, look for dyspareunia, postcoital bleed. And that is for? Why do you want to look for dyspareunia, postcoital bleed?
That is for atrophic vaginitis and
Atrophic vaginitis, yes. Contraception, and here her partner had vasectomy, okay. So STIs, children, but the cancer screens are the most important. So look whether she is regular with her cervical cancer screening, breast cancer, and bowel cancer. So she's up to date with her CST, but mammogram and bowel cancer screening she hasn't done, okay. So just your differentials, just 2 of them is enough, okay. So you can look for any weather preference or bowel habits for thyroid, any milky breast discharge for hyperprolactinemia, and you can also look whether she is generally an anxious person, okay. So that is enough. So, but here you know that she is having perimenopause. She is going in for perimenopausal symptoms, which is affecting her quality of life, and she is a candidate for HRT. So if you have to start her on HRT, what you have to do is rule out the contraindications of HRT, okay? So when you come to contraindications, is DVT. So look for any clotting in her legs, any recurrent chest pain, any recent heart attacks, any uncontrolled high blood pressure. So this is all the cardiovascular contraindications. So when you come to central nervous system, is stroke. So you check for any incidence of stroke. When you come to the GI system, it is liver. So you look for any active liver disease because HRT is processed in the liver, okay? So you look for any active liver disease. Then next contraindication is all cancers. So look for any cancers, any history of cancers as far as her uterus, her breast and ovaries are concerned, and a general question for cancer, weight loss, lumps, bumps around the body, okay? So you make sure that you look into the contraindications of HRT. And this is a critical key point as far as the history goes. Okay. So you have to make sure that you ask for contraindications. So it's just like the OC pill case. Do you remember the OC pill case that I discussed with you? So in that case also, it's the contraindications that are the critical key points. Okay. So for the people who have joined for the trial class, some cases will have critical key points. So if you don't cover the critical key points, you will be scored down for the whole station. Okay. So other cases will just be having key points alone, but some cases will have critical key points. Okay. All right. Her lifestyle also you can look for whether she's following a healthy lifestyle, a sad history. Then we also look for any family history of genital cancers, breast cancer. So this is how the history should go. So always your history should start with the history of presenting compliance. Then you look for associated symptoms. Then if it is a gynecological case, go for the period history, sexual history. And if you have any questions for differentials, frame the differentials, okay? So that's the structure as far as a gynecological history goes. So here, in addition, because you're thinking about HRT, you make sure that you look for contraindications for HRT as well, okay? Any questions regarding the history that you have? Am I clear with the history? Okay. So now coming to the condition that she is having. So you say that the reason behind the hot flashes, the sleep disturbance, and the irregular periods could be because you are going in for menopause, and it's because of a reduction in estrogen, the female hormone, as the ovaries start shutting down. Okay. So you say that you can benefit by starting on HRT or hormone replacement therapy. Okay. So say that hormone replacement therapy, so it has got a combination of hormones, estrogen and progesterone, which replaces the lost estrogen from your ovaries. So the role of progesterone is to reduce the uterine lining thickening that is caused by estrogen alone. So progesterone has got nothing to do with perimenopausal symptoms. So perimenopausal symptoms are usually alleviated by estrogen, okay? But why progesterone is added is because if you give estrogen alone, estrogen can bring about an endometrial hyperplasia, and that can predispose her to endometrial cancer. So in order to prevent that, that is why we add progesterone to HRT, okay? Otherwise, progesterone has nothing to do with perimenopausal symptoms, okay? So you just make her aware why the progesterone is being added to estrogen, okay? So tell her before you start her on HRT, you need to do further investigations. So mainly a thyroid function test, because thyroid disturbances can also cause similar symptoms. So it can cause all the vasomotor symptoms. It can also cause irregularity in the periods. And then you also estimate the hormones, FSH and LH, among which FSH is the most important one. Okay. So FSH and LH will be going high if she is going in for menopause. Okay. And also arrange for a mammogram. So because HRT carry a risk of causing breast cancer. So you have to make sure that she is not having any breast cancer before you start her on HRT. Then you also do a transvaginal ultrasound because she is having irregular periods. So just to make sure that she is not having any cancers. And here her last menstrual period has been delayed. So you also do a urine pregnancy test. Okay. And then tell her she'll be started on cyclical HRT. And then she'll get cyclical bleeds rather than irregular periods. Okay. So there are 3 different ways by which you can give HRT. One is a cyclical HRT or a sequential HRT. Then we have continuous combined HRT. And then we have estrogen alone HRT. Okay. So cyclical HRT is we take like 28 days. We give estrogen continuously for these 28 days. And then you add progesterone during the last 10 days. So when you withdraw the progesterone, the patient gets the periods or she'll get cyclical bleeds. Okay. And then you take another 28 days. So estrogen will go on continuously. But during the last 10 days of every 28 days, you give the progesterone. Okay. So this will alleviate the perimenopausal symptoms. At the same time, the periods will also become regular. Okay. So this we usually give in perimenopausal women and also menopausal women up to 1 year of menopause. So that's the indication for cyclical HRT. Okay. After 1 year of menopause, that is in their postmenopausal period, we give continuous combined HRT. So in continuous combined, she'll go for continuous estrogen, continuous progesterone. So we are not withdrawing any hormones there. So she will not get a bleed when she's on continuous combined. When do you give an estrogen alone HRT? In which condition do you give an estrogen alone HRT?
When the uterus is not there?
When there is no uterus. Okay, so that is when we give estrogen alone HRT. Because if there is no uterus, there is no need to give progesterone, is it? So that is when we give estrogen alone HRT. Okay, so these are the 3 different methods by which we give HRT. So cyclical HRT in perimenopausal and menopause up to 1 year. Continuous combined postmenopausal, that after 1 year of menopause. Estrogen alone HRT if she has no uterus. Okay. So here, because she is perimenopausal, we put her on cyclical HRT. So lifestyle modifications also, you can say, like cut down on spicy foods, limit coffee, alcohol within safe limits. And you have to follow her up in 6 to 8 weeks of putting her on HRT. Thereafter, 6 monthly and yearly. Again, she has to be up to date with all the cancer screens. So when you come to benefits of HRT, so the benefit is it will alleviate all the perimenopausal symptoms. Her sleep improves. It also brings about bone mineral density or prevents osteoporosis or bone thinning. So also it's protective against bowel cancer. So that's the cancer that it will be protecting against. Okay. So when you come to the risk, again, clotting in her leg vessels, VTE, stroke also carries a risk of breast cancer, gallbladder disease. Why a gallbladder disease? How does it bring about a gallbladder disease? Because of the cholestasis that is brought about by estrogen in the HRT. Okay, so that's how a gallbladder disease happens. Okay, so you can give her all the printouts regarding that, and you can also see her with the results. So this is perimenopausal HRT. Came twice last year. Okay, so I haven't seen it this year, but has come twice last year. Okay. Any questions that you have regarding perimenopausal HRT?
Doctor, I have a question. For cyclical HRT, do we give progesterone for last 10 days or for the last 14 days?
No, you can give it from 10 to 12 days to
Okay.
begin with. Okay, not 14 days.
Okay, thank you.
All right. Yeah.
I have one question.
Yeah.
Do you have to do the progesterone estrogen test as well, or just LH FSH?
No. Just FSH. Usually we do FSH alone. Okay. All right. No
Why,
need to look into
no need.
estrogen. No.
But we only do estrogen progesterone in other cases, right? Like in amenorrhea cases.
Oh, yes. Estrogen is not a big deal. Okay. So it's mainly the pituitary hormones that you check on. FSH is the main thing that you check on. Okay.
Okay.
Any other questions? Perimenopausal HRT?
Doctor, in cyclical HRT, 28 days we give the estrogen.
Yeah.
After that, we start the progesterone for 10 to 12 days.
No. During the last 10 days of the 28 days, you start progesterone.
Okay.
Okay. That's why it's called cyclical, is it? So estrogen continuously for 28 days. During the last 10 days of this 28 days, you give progesterone.
Okay.
So when
Doctor,
you withdraw the progesterone, she will get a bleed, is it? Yeah.
Doctor, this is only on the perimenopausal, right? The cyclical.
Cyclical, you can give it up menopausal up to 1 year also.
Yeah, and the another one is after the menopause of 1 year, right?
After 1 year, you give continuous combined.
Okay, so cyclical or continuous, only 2, right? Mostly.
And
Yeah.
the estrogen alone if she doesn't have a uterus.
Okay. Yeah.
Any other questions that you have? No? Clear?
And doctor, do you have to do ultrasound for every cases like this with irregular periods?
She's having irregular bleeding. You have to. Okay.
In other cases as well, as just like young women with irregular bleeding, in that case also you have to do ultrasound, right? Same.
Sorry,
same
Prasanna, speak a little slow. I can't follow you.
In ultrasound, because of irregular bleeding, we are doing that, right? Irregular periods, we are doing ultrasound,
Yes.
right? Okay.
Yeah. That's just to rule out any endometrial hyperplasia or endometrial cancers. Okay. Any other questions? No? Okay. So if we have no questions, then we'll move on to the next one. So after Pavna, Joe have already done, is it?
It's me, Doc.
Yeah, Tina. Okay. I'll give you the case, Tina. Just a moment. Yeah. Just we can skip. Yeah. This is your case, Tina. Read through it. I'll time you 2 minutes, okay? Thank you. You can start, Tina.
Hi, Kath. I'm Dr. Tina. I'm your doctor today here. So, Kath, can you tell me more about your concern? As I can see, you have bleeding after intercourse. So, can you tell me more about it?
A bit embarrassed to talk to you regarding this, doctor.
Kath, I assured complete confidentiality. So, whatever you talk, it'll be between you and me.
Thank you. So that is whenever I get intimate with my partner, I'm having this bleed, and it has been there since the last 2 months. So I'm getting very much worried about this.
Okay, can you tell me, do you have pain when this happens?
Got a bit of pain also.
Okay, is it during intercourse or is it along with the bleed?
No, bleed happens after intercourse. So I have pain at the time of having sex.
Okay. Can you tell me what color of the bleed is?
It's just like my period blood.
Do you see any clots or any tissues with it?
No clots, no tissues.
How is it a lot or is it only little bit?
How can I say that?
Mm. Do you use pads for this?
No pads, it just stains my undergarment, and sometimes I use one pad. That's all.
Okay. Any fishy smell or anything?
It's not smelly.
Okay. So Kat, can you tell me about your period? When did you have your last periods?
That was 3 weeks back.
Okay, is it regular?
Yeah, it comes every month.
How many days is your period for?
3 to 4.
Okay. So is it like the normal bleed?
Yeah, the flow is normal. Yeah.
Okay. And any complaint of fever recently?
No fever.
Any discharge from your vagina you've noticed?
No abnormal discharge.
Do you feel burning when you pee?
No,
How is your bowel movement?
it's regular.
Any headache, nausea, vomiting?
No,
Mm. So, are you with a stable partner, Kat?
yes.
So is this so this only started last 2 months, as I can see. So
Yeah.
can you tell me like how was it before?
What do you mean?
Were you in a sexual relationship prior to the 2 months, or is it only from 2 months?
No, I'm sexually active since the last, say, around 5 years.
Okay. Last 5 years. So this is the first time you had a bleed after your intercourse,
Yes.
like from the 2 months period.
Yes.
Okay. So, Kat, did you get a HPV vaccine called a Gardasil vaccine, which was supposed to have? Do you remember taking the vaccine?
I think so, doctor. Not very sure.
Okay. Do you smoke?
I never smoked.
Any history of alcohol?
Occasional.
Can you tell me what occasional means? Like, how frequently do you?
Not a huge drinker, doctor.
Any recreational drugs?
Never did drugs.
Okay. Kat, can you also tell me about your partner? Is it a stable partner?
Yes.
Do you have is your partner screened for STIs or any kind of infections prior?
What is STI?
It's a sexually transmitted infections.
I don't think so.
Okay. And any past medical, or do you use any medications or anything?
Just some supplements.
Okay. Supplements for?
Just multivitamins.
Okay. And any
Yeah, 5 minutes is over, Tina.
Okay, hello examiner. I would like to know the general appearance of my patient Kat.
She appears a bit concerned.
Any lymphadenopathy, any pallor?
No.
Her vital signs?
All stable.
Okay. Her respiratory and CNS, just a quick finding.
All good.
Her abdomen, any tenderness on her abdomen?
No tetanus.
any palpable mass or anything?
No.
Any kind of trauma to the abdomen?
Trauma to
I
the
no, I mean like any kind of
No, anyways.
okay. And inspection that. And any adnexal mass seen? That is in pelvic examination.
No.
Sorry.
Mm.
On pelvic exam, I would like to know is the cervical as open or closed?
Closed.
Okay. Shit, I forgot to ask about the pregnancy. And the vulval and vagina, is there any bleeding or discharge?
No bleeding, no discharge seen.
Any rash?
No.
Speculum, I said the office test, any
Speculum, this is what you see.
cervical. So it's an infection. Okay. Office test, urine dipstick and blood sugar levels.
All good.
Thank you, examiner. Doc, I know the diagnosis is some infection or something. I think it's a cervical ectropion. It's rare. I'm not sure.
I told you, never say not sure. Okay. Last time also I told you. So you
I
put what you
think
put on
I'm
the
not
table
the
with your
problem.
differentials. Say
So
your
the
differentials.
differentials, I think I was thinking of as I can see bleeding after intercourse, so I thought about a trauma, and then I thought about this in had everything before the started.
Take your time. Don't rush. Even though you have finished your time, take your time.
I thought it's a postcoital bleed. I thought about dyspareunia and then
Take your time. Think calmly. Okay.
I thought about any sexually transmitted infections. It's only 28 years. I thought about HPV, but there's no warts or any rashes.
You say the differentials.
And then
But what is your diagnosis?
I'm not sure.
Don't say not sure.
I know it's from the image. I think it's. I'm not sure about cervical ectropion.
Don't say not sure. It's a cervical ectropion.
Oh, okay.
Don't say not sure, not sure. I told you last time also. Okay.
So I don't want to be wrong, so I'm not
why,
sure.
if you're wrong, that's okay, is it? So even for the exam, if you think about a thing, say it. Okay. Because otherwise, if you withhold it, even if you're wrong, it's okay. But sometimes it can save you a station, is it? So if you just now said that this is a cervical ectropion, you would have passed the station. Is it? So that's what I told you last time also. Never say not sure. Say what you have on your mind. Okay. And that can even save your station, just like now. Okay.
Yes,
So tell me, what is a cervical ectropion?
Not
Do you
sure.
know what a cervical? Again,
I don't.
sure.
I don't remember. To explain, I'm not
counseling. You don't know what a cervical ectropion
I
is.
know it's like the redness from the picture. I recognize that it's a cervical ectropion, the picture, but then I don't exactly remember like how to explain it.
Not sure regarding
Yes.
examination. Okay, all right. But your diagnosis is cervical ectropion. Okay, all right. Coming to the presentation, Tina. Time management you have to concentrate on. Okay, all right. You took a lot of time. You asked me very good questions regarding the bleed. Okay, so that was excellent. You asked me almost everything regarding the bleed. It was mainly the associated symptoms that was not covered in full. Okay, so if there is a postcoital bleed, you have to think about any abdominal pain that she's having. Okay. At the same time, you have to look for any rash, blisters, ulcers that is there. Okay. So all these should come in the associated symptoms. Period history, you asked me for the last menstrual period, but you didn't ask it in full. You have to look for any pain
Yes.
at the time of periods. Okay. Any intermenstrual bleed, all these are important. Sexual history, again, you missed on some key things. Okay. Contraception. Okay. So if you had asked me the contraception, I am on OC pills. Okay. All right. So also CST. You asked me about HPV vaccine, but she's 28 years, is it? So you have to ask for the CST. That was a critical key point here. Okay. So CST, you have to look whether it is up to date, any abnormal results that she has. Okay. Why CST is a critical key point in this case, Tina?
Because she was sexually active for a long period, and then she has bleeding after intercourse since last 2 months, and she's also on contraceptive pills.
No, I am asking why a CST. Asking CST comes as a critical key point in this case.
I'm not sure exactly, because I didn't ask, because she's only 28 years, I didn't ask. And then the second thing is, and
No, I'm asking why do you want to ask for the CST in this case?
because of the bleed after intercourse,
So what is a cardinal symptom of
cervical cancer.
cervical cancer? Okay, so that's why you have to check on that. So that's a critical key point here. Okay.
Because of the
After
age,
HPV
because of the age, I didn't ask that question with the CST.
Why? At what age does CST start?
After the sexual activity
Oh
start.
dear. When does a CST start? At what age? Once they are sexually active.
Okay.
25 years. It
25.
starts like 25 years once they're sexually active, is it? And this postcoital bleeding can be a cardinal symptom of cervical cancer. So you have to make sure that she's up to date with the CST. So that's why it becomes like a critical key point in this case. Okay. So STIs you ask for in the partner, but you have to ask for her, is it? Has she ever been screened for sexually transmitted infections? You're not worried about the partner, it's her that we are worried about. Okay. So lifestyle and all those you covered. You can also look for any family history of cancers. Okay. So when you came to the examination, till abdomen, it was very good. Okay. After that, it was, but actually, in a gynecological exam, it's the pelvic exam that is important, is it?
Yes.
So you have to make sure that you do it in a structured way. Okay. But after that, you ask me, like inspection, you ask me for rash and abnormal discharge and all those. Then speculum. When you put in a speculum, always ask the examiner whether the cervix is healthy. Okay. So then only the examiner will show you the picture. Okay. Well, where did the bimanual go, Tina? Did
I
you
don't know.
do a bimanual exam? That was also important in this case, okay? Because many a times when you see the picture, you get so carried away with the picture that you forget to do the per-vaginal exam, okay? But here, that per-vaginal exam is also important, okay? Finish it with the office.
A question, like in what cases do we do a bimanual exam? Like when do we do it?
In all gynecological cases, you have to do a bimanual exam unless she is having any active abnormal vaginal discharge. And also, if she's not if she's a virgin, you don't go for speculum or bimanual exam. Okay. So in all other cases, you have to do a bimanual because she might be having something inside the uterus. She might be having something inside the ovaries, is it? So you have to go for it. So this is actually a cervical ectropion. Okay, what's a cervical ectropion? Anyone?
Migration of endocervical cell into ectocervix.
So it's actually a migration of the endocervical cells into the ectocervix. Okay, so that is a cervical ectropion. And why does that happen? What are the reasons for a cervical ectropion?
OCP.
OC pills. And any other reasons?
Pregnancy can be more common.
Pregnancy, excellent, Joe. Pregnancy, then?
There was one more.
Also in adolescence, okay. So in teenagers, also the estrogen levels will be pretty high. So in these three categories of women, you can get a cervical ectropion. Okay. So this is a case that has come again last year. Haven't seen it this year, but this came like twice last year. Okay. So make sure that you know this case. So I'll take you through this case. So this is 28-year-old cat at your GP complaining of bleeding after intercourse since the last 2 months. And she appears very much concerned about this. So the broad spectrum under which you can put this case is a postcoital bleeding. Okay. So when you think about postcoital bleeding, which is the first structure that you will concentrate on?
Cancer.
Which is the first structure that you will concentrate on?
Cervix.
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 Cervix is the first one that you have to consider. Okay. So when it comes to cervix, what can be the causes?
Cervicitis.
A cervicitis, how does a cervicitis happen?
It is caused by that is chlamydia and gonorrhea if sexually active.
TIs and
Could be
infections.
STIs, sexually transmitted infections. Okay. So chlamydia, gonorrhea. Then what's the second condition that you'll think about?
Cervical ectropion.
Then?
Polyp, cervix.
Cervical polyps. Then?
Cervical cancer.
Cervical cancer. So these 4 things are the things that you have to consider from the cervix. Okay. So then what is the next structure that you'll think about if there is a PCB?
Ovary.
No.
Vagina. Vagina.
Uterus. Uterus is the next one that you have to think about. So when you come to the uterus, what are the reasons for a postcoital bleed from the uterus?
Endometrial cancer.
And
PID.
PID, endometrial cancer and PID comes. Okay. Then you have to think about next. Which next structure will you think about?
Vagina. Vagina.
Ovary.
No, ovaries will not cause postcoital bleed. Vagina. Okay, so now we have to think about all the vaginal causes. So think about cervix, cervical causes to begin with, then the uterus, then the vagina. Okay, all right. So when you come to the causes, cervicitis, secondary to STIs like chlamydia, gonorrhea, trichomoniasis, cervical cancer. So, PCB is a cardinal symptom of cervical cancer. But having said that, it's not the most common reason for postcoital bleeding. Okay. But even if there is a slight chance of cancer, have to make sure that you have to rule it out. Okay. So next is cervical ectropion or cervical polyps, then uterus, endometrial cancer, PID, then the vagina. So vaginal sores like herpes, syphilis, vaginitis that happens with candidiasis, bacterial vaginosis, vaginal cancer. Okay. So this is how the differentials should go. So when you go inside and show her confidentiality, ask her concern. So she is much concerned that she is having a bleeding after she gets intimate with her partner. So you ask since how long? So it has been there since the last 2 months. So you ask, is it like on and off or every time that you get intimate with your partner? And she will tell you it's almost every time. Okay. So check on the color. So it's just reddish, just like a period blood. Check on the severity. So look whether she needs to use any pads, and she'll tell you she just stains her undergarments and sometimes she needs to use a pad. Look whether it is a smelly bleed. So if it is a smelly bleed, what does that go in favor of?
Maybe chlamydia and infection.
Not chlamydia, I told you, it's not smelly. PID said if it is a smelly bleed, that goes in favor of PID. Cancers can also be smelly too. Okay. And you look whether it is worsening and whether this is the first episode that she is having this. Come to associated symptoms. So anything with the genital area, you always check for abdominal pain. And abdominal pain can also happen in which condition? From your differentials? PID, yes. So you also look for any abnormal vaginal discharge. So that's a very important question. And she tells you no. So when she says there is no abnormal vaginal discharge, That's actually ruling out chlamydia, gonorrhea, trichomoniasis, cervicitis. So it's also ruling out all the candidiasis, bacterial vaginosis. Okay. So all these are getting ruled out when you ask for abnormal vaginal discharge. Then a general question for cancers, weight loss, lumps or bumps around the body. And also you check for anything bulging into the vagina that she feels like cervical polyps. Sometimes she can feel like bulging into the vagina. Also look for any rash, blisters, ulcers associated. So that will rule out all the vaginal sores, herpes, syphilis, and all those. Okay. Candidiasis, bacterial vaginosis, all these can cause rash. And also there'll be blisters and ulcers with herpes, syphilis. So, it's not going to be any vaginal sores. It's not going to be vaginitis. It's not going to be cervicitis. Okay. Again, unlikely it's a cervical polyp or a PID because, again, there is no abnormal vaginal discharge. So all these are getting ruled out. So now you have cervical cancer, you have endometrial cancer. But again, she is not having any weight loss, lumps or bumps around the body. So what is left behind is a cervical ectropion. Okay, so that's how you come to a clue regarding your diagnosis. So go for the period history next. So last menstrual period, all the questions regarding the periods need to be asked because periods can get altered in which condition? From your differentials. Endometrial cancer, is it? So she can present with menorrhagia. Cervical cancer also can result in period disturbances. Okay. So all these PID also can result in period disturbances. So you have to make sure that you ask all the questions regarding the periods. But last menstrual period is also important. So just rule out a pregnancy. So you ask for the regularity, the number of bleeding days, the heaviness of the flow. But you also look for any pain, any intermenstrual bleed or intermenstrual pain, okay? Because all these can happen with PID as well. So go for the sexual history, look whether she's with a stable partner. But you also look for any pain at the time of intercourse along with the bleed. So she's having pain here, okay? So no history of sexually transmitted infections. So when you come to the contraception, that is the one that gives you a clue regarding cervical ectropion. So she'll tell you that she's on OZ pills. So you look at the type of the OZ pills, since how long she's on OZ pills, and you also look for any side effects. So here she's on OZ pills for the last 5 years, okay? And also she's comfortable with the pills. So, it could be a cervical ectropion because she's having dyspareunia along with postcoital bleed. At the same time, she's on OZ pills as well. So pregnancies, miscarriages also, critical key points, CST. So look whether she's up to date with the CST, also the results, okay? So because cervical cancer is a postcoital bleed is a cardinal symptom of cervical cancer. You also look whether she had taken the HPV vaccine, okay? So lifestyle, again, which predisposes to cervical cancer among SAD? Smoking. So you have to make sure that you check on smoking. Other medical surgical conditions, medications, allergies, or family history of cancers. Okay. So this is how the history should go. So when you come to the examination, general appearance, general exam, also check on the BMI of the patient, but lymphadenopathy is the most important one. Okay. And that's for cancers, that's for other infections as well. Check on the vitals, mainly temperature, cardiovascular respi, abdomen. You look whether it is soft, not tender as well. It's a pelvic exam that will give you the diagnosis. So start with the inspection of the vulva vagina. Look for any bleed that she's having at the moment. Also make sure that she's not having any other abnormal vaginal discharge. Also look for rash. So just make sure that there is no vaginal infections, no cervical infections that is causing the bleed. Going for the speculum. So check on the cervix, whether the cervix is healthy or not. So that is when the examiner will give you the picture, okay? So this is actually a picture of cervical ectropion. So cervical ectropion will be seen as a red ring around the cervical OS. Okay. But otherwise, you can see, how will you differentiate it from a cervical cancer? How can you differentiate that?
Transitional zones of the sun.
When you look into that, can you see the transitional zone? How do you differentiate it from a cervical cancer?
Irregularity of the could be the cancer can be irregular.
Oh, this is also a bit irregular.
Signs of bleeding or something like that.
The color
It might be more
Usually, the
spread.
whole cervix
Yeah,
will
the
be
more
unhealthy in
more spread.
appearance. Okay. So there'll be friable tissue all throughout the cervix. So that is the one that rules out a cervical cancer. Okay. So when you come to never miss on the bimanual exam, okay. So sometimes instead of giving you a picture, the examiner will tell you, you can see a red ring around the OS. So, a red ring around the OS goes in favor of cervical ectropion. So you also ask for any bleed, abnormal discharge, which she's not having, and check on the vaginal walls. But never miss the per-vaginal exam, okay? Because you can rule out endometrial cancer PID only if you do a per-vaginal exam. So start with the CMT. So the CMT is negative, but uterine size you have to look for, and the uterine size is normal. So again, it means it's not a bulky uterus that you get in endometrial cancers. No tenderness. So what is that ruling out?
PID.
PID, yes. At Nexa, again, no mass, no tenderness, again, ruling out a PID, okay. But make sure that you do a UPT, because in pregnancy also you can get a cervical ectropion, and she is sexually active. So just make sure that you do a UPT and a urine dipstick blood sugar level, okay. So when you come to the diagnosis, tell her the reason behind the bleeding that she has when she gets intimate with her partner is a cervical ectropion. So you say that the cervix or the neck of your womb has got two surfaces, an outer surface called the ectocervix and an inner surface called the endocervix. So the outer surface is lined by flat cells, inner surface lined by tall cells. And these two meet at the opening of the cervix. So when there is a migration of the inner cells into the outer cells, it will be seen as a red ring around your opening of the cervix, which I have seen on examination of the cervix. Okay. So this usually happens under estrogenic influence. So the OZ pills that you have been taking for long could be the reason. So it can cause a postcoital bleed or bleeding after intercourse. Sometimes it can also cause pain at the time of sexual activity. Also, you can sometimes get abnormal mucosal discharge. So all these are the other symptoms of a cervical ectropion. Okay. So that's how you explain a cervical ectropion. Okay. So if they ask you the differentials, you can say that I was also thinking about like an infection in the cervix or in the vagina, like sexually transmitted infections, or even yeast infections like Candida, but you have no abnormal discharge. It's also a cardinal symptom of cervical cancer, but I can see that you are up to date with your cervical cancer screening test. It can also be some growths in the cervix, like polyps, which I have not seen. Could be a cancer inside the uterus, but your uterine size is normal on examination, have no weight loss or period disturbances. Can be an infection inside the uterus and the ovaries, which we call as a pelvic inflammatory disease. But here you should be running a fever, and there'll be like tenderness in the uterus and the tubes, which you do not have. Okay. It could be ulcers in the vagina, like herpetic ulcers or syphilitic ulcers, but you have no ulcers or rash in your vagina. Okay. So these are the differentials that I was thinking about. Okay. All right. So this is a case of postcoital bleed because of cervical ectropion. Any questions that you have for cervical ectropion or this case?
Doctor, can they ask about management of this?
So far, they haven't asked the management.
We can say change the OCP.
Yeah, of course, you have to stop the OC pills, put her on progesterone only contraceptives, or she can just use barrier methods like condoms. But cervical ectropion has to be treated. So you have to refer her to the specialist, and then the cervical ectropion has to be done cryo or ablation procedures.
Okay, thank you.
Yeah. Any other questions?
What are the investigations to be done, doctor, here? Like basic blood test, and then urine examination and
Investigation for cervical ectropion?
yeah.
Why do you want to do a urine investigations?
To look for the other differentials. Do you need to do like
No need.
no need? Okay.
But if it is a single episode of PCB, the cervix is healthy on gynecological assessment, have to do a co-test. Okay. So if the CST is normal, you have to do an STI screen for chlamydia. If that is negative, no further test. Okay. So this is but here, it's a cervical ectropion that is causing the problem. So here, of course, you do a co-test and STI screen, and then you refer her to the specialist for the treatment of cervical ectropion, which will be with ablation or cryo. Okay. And ask her to stop the OC pills and change it to a progesterone-containing one or barrier methods. Okay.
Doctor, can I ask you a question, please?
Yeah, sure.
When we have to count the differentials with causes, if we run out of time, always we have to say this. I was thinking of this because of this, and
yeah, it's better to say that the reasoning. Okay, so the differentials and the reasoning. Okay. Otherwise, if you think you're running out of time, you just say the causes without reasons.
okay.
Any other questions?
Doctor, can we do in the way like we tell all the differentials and then we start again? Like I was thinking this thing, but it's not because of this. I was saying this, but this is not the reason.
Say the diagnosis to begin with. So even if you miss one or two differentials, it doesn't matter. But if you don't say the diagnosis and you
of course, after
time,
yes,
that
after
will cost
diagnosis.
your station. After diagnosis, you can say the differentials.
Okay. Yes. Okay. Thank you. And doctor, I have one more question, please.
Yes.
Will we get the recording of this class? Because I'm joining for the first time, and yeah, I have to pick up my kids, and I wonder I will miss this part.
Yeah, you can contact the IT department, Mahwish.
Okay.
Okay. And do you know our number?
Yeah, I think, yeah.
Yeah, so you can just ring them up and ask for the IT department. Okay.
Okay. Thank you, doctor.
No worries, Mahwish. All right. Any other questions that you have for PCB? No? All good? Okay. Okay. So if you have no questions, then we'll move on to the next one. So who will be doing the next one?
I think that's me.
Diala. Okay. Diala, I'll give you the case. Yeah, this is your case, Diala. Read through it. It'll take me 2 minutes. Laila, you can start.
Yes. Hi, I am Dr. Diala. Mary, as I have your ultrasound, abdominal ultrasound in my hands, I want to explain it to you regarding the pain that you have in your low abdomen. The ultrasound shows that I want to draw the picture. Is
Yeah,
that
draw the picture. Show.
yeah?
Do it, Laila. Draw the picture and show.
Mm. That, as you know, we have two ovaries that every month gives an egg. When the follicle in the ovary ruptured,
What is a follicle, doctor?
yeah, it is the part of ovary which every month gives the ova or the egg which travel to uterus, and if there is a sperm that cause pregnancy, if not, it will cause the menstrual period, the bleeding will come. So as we see, this is the ovary and here the follicle. I don't know if it's
I can't see that. Yeah, it's okay.
yeah. I'm not good at drawing, but
It's
it's
okay.
yeah. The ultrasound shows that your ovary has the follicle ruptured. That means it's opened, and as usual, and it happens usually in the mid of your cycle. And it's usually cause some fluids in the abdomen, which is usually normal in mid-cycle. Um, your appendix, which is a part of the your gut or intestinal gut, it is normal, no infection or inflammation, which can be the cause of the pain, but it is here not the cause. And your sac of gallbladder, it is the sac under the liver that it's important for fat ingestions. It has three stones, but the size of the stone is small, and there is no thickening in the wall. That means no infection or inflammation. So it ruled out the cause of the pain. And as your period was 2 weeks ago, so it is the cause of the pain is the ovulation pain. Can we say that? Yeah.
So
Yeah,
why the pain, doctor?
the pain because because of the fluids in the pouch of Douglas, which is a sac between the uterus and the lower part of gut. This fluid can make irritation and can cause this pain. But it is usually normal, and this is the no, further one. About further I'm not sure about further management if we need to do any.
Think you have time left.
Yeah. About your gallbladder, no need for any other investigation or no surgery needed. And about as it is it is normal ovulation pain. We you can take when a simple painkiller medication like paracetamol. Yeah.
So what if this becomes recurrent, doctor?
If you have recurrent, you can take if it is recurrent, I don't know. We can give OCP.
How does that help?
It can help with ovulation, stop ovulation, so the pain will be stopped as the ovulation will stop by the oral contraceptive pill.
Okay, finished?
Yes.
Yeah. Look, Diala, regarding the explanation, that is why you were a bit like hesitant, okay? So you have to say what the follicles are and what happens when a follicle ruptures, why the pain is happening. And ovum will not travel into the uterus, okay? So ovum will be
The
there
tube.
in the
The
tube. It's a
Yeah.
sperm that travels into the tube, okay? So don't say that ovum will travel down into the uterus, okay? And then pouch of Douglas also you have to say regarding what a pouch of Douglas is, okay? So you have to say the specific thing. And you told me appendix is normal. Is it written that the appendix is normal?
Not visualized.
Mm.
So if it is inflamed, it will be or no. Mhm.
No, if it is retrocecal, you don't visualize an appendix. So she'll ask you a question like if the appendix, you are saying that appendix is not seen. So if you're not seeing the appendix, how can you rule out an appendicitis? Because my sister had a similar pain and it was appendicitis for her.
By the confirmative examination, CT scan.
Is that
Or
how you say? So then if you just say this pain is because of ovulation.
okay, as this, yeah, because you don't have any symptoms like fever or diarrhea to have appendicitis, or we need to. You asked me about investigation. Full blood count could be done.
No, not investigation. She is asking you why not an appendicitis here?
Because the time of the pain and your last period
Yes, in
time.
appendicitis also you get a right lower abdominal pain.
But because your period time 2 weeks ago, that means
This does not tell you that this is ovulation pain. So it can be appendicitis. Ovulation pain will not happen in every woman, is it?
Yeah, it can be appendicitis, but usually it comes with fever, vomiting, abdominal pain. Yeah.
Appendix is not a diagnosis through investigations.
Yes.
It is with clinical symptoms and signs that you have to diagnose an appendicitis. Okay. So even if the appendix is not visualized, because she is not having any clinical signs or symptoms, that is why you say it is not an appendicitis. Okay. So that also requires an explanation here. And this is ovulation pain, mid-cycle pain, but that is not because of the fluid in the pouch of Douglas alone. Okay. So what's the reason behind an ovulation pain? Anyone? What causes an ovulation pain?
Due to
Follicular rupture.
Follicular rupture will not cause pain.
due to the rupture of the
Follicle is just a small sac. It won't cause pain when it ruptures.
Because of the decrease of estrogen level.
That
There is
causes the pain?
actually, doctor, when they rupture of follicle, there is some fluid also comes out, and that will collect it at the pouch of lower part of tummy cavity. We call the covering by the peritoneum, and it will irritate that peritoneum, and that result in the pain.
So it's a local peritonitis that happens when the follicle ruptures. Okay. So along with that, the fluid in the pouch of Douglas can also cause the pain. So that's the reasoning for the pain that she is having. Okay. So that you have to tell her the reason why the pain happens. And when it comes to further management, of course, it will settle on its own. So you just give her basic analgesics. She can also place some warm compressors over that. Okay. Hot packs, warm compressors. So analgesics also, you have to ask her to take rest during this time. Okay. So, but always give her the warning signs. Like if she experiences any bleeding or if she experiences any other abnormal vaginal discharge, ask her to come back. Okay. So then, well, if it becomes recurrent, then you can start her on OZ pills as well. Okay. So that's how the management should go. Okay, all right. So it's actually the explanation that you were a bit defective and the reasoning why the pain happens. Okay, and that appendix also need to be said well. Okay, all right. Yeah. Okay. So I'll take you through this case. So this case, I haven't seen it last year, but it came in 2024. So you have a chance that you might get it this year, okay? Because as I told you, the 2024 cases are making a comeback now, okay? So I'll take you through this. So this is 24-year-old Mary coming to your ED where you are the HMO with complaints of right lower abdominal pain for the past 1 hour. So she has no other symptoms. Her vitals are stable. So after seeing her, you ordered a pelvic abdominal ultrasound, which is showing a ruptured ovarian follicle in the right ovary, free fluid in the pouch of Douglas, appendix not visualized, gallbladder with 3 stones, each of 1.5 millimeter, and the gallbladder wall thickness is normal. Her last menstrual period was 2 weeks ago. Her periods are usually regular. So there are a lot of things that is given in the scenario, is it? So when you look into that, ultrasound findings, so it's a right lower abdominal pain. So what is the first thing that you think about?
Appendicitis.
Appendicitis.
That's the first thing that you have to think about. Okay. But when you look into that, appendix is not visualized here. Okay. So how do you make sure that this is not appendicitis from the scenario?
Because there is a free fluids, the period 2 weeks ago.
No. How will you rule out appendicitis from the scenario?
So there is
Vitals are stable.
Ruptured ovarian follicle.
No, she has
No.
no other symptoms.
Mm,
Is it?
and this
So you know that if she is having appendicitis, there should be fever. There should be also like other symptoms like constipation or diarrhea she might be having. Okay. So all these could be there. And her vitals are also stable. So she's not having any fever at the moment. Okay. So that is the one that is ruling out appendicitis, even though the appendix is not visualized. Okay. So that is how you correlate with things and rule out things. So again, gallbladder is the next one. So gallbladder is also having 3 stones, each of 1.5 millimeter, and gallbladder wall thickness is also normal. Okay. So what does that mean for you? It's just an incidental finding. Okay. So if she is having any gallbladder stone pain, where will the pain be?
Upper right quadrant.
So it will be towards the right upper abdomen, is it? So here she is just having a right lower abdominal pain. So that means the gallbladder finding is just the stone in the gallbladder is just an incidental finding. And the stones are also very small. And on top of that, the gallbladder wall thickness is normal. So what does that mean?
No inflammation.
No infection, no inflammation within the gallbladder. Okay, so that is again ruled out. But when you look into the next one, showing a ruptured ovarian follicle in the right ovary, and what tells you that this is an ovulation pain?
Because it is in the her period 2 weeks ago.
2 weeks ago. So the last menstrual period was 2 weeks back, and her periods are usually regular. So this is the time of her ovulation, okay? And it's a ruptured ovarian follicle. So it's just an mid-cycle pain that she is having. What's the other name for mid-cycle pain?
Ovulation pain.
Mittelschmerz syndrome.
Mittelschmerz, not syndrome. There is no syndrome. It's
Okay.
just Mittelschmerz. Okay, all right. So it's called Mittelschmerz. So even if you don't get the name Mittelschmerz, that's okay. You can just say mid-cycle pain or ovulation pain. Okay. So when you read through the task, there is no history taking here. So it's just explain the results to Mary, discuss with her the most probable diagnosis, explain to her the further management. Okay. So, it's a mid-cycle pain or an ovulation pain. And the reason behind the pain is because when the follicle ruptures, there'll be discharge of a small amount of fluid and blood into the peritoneal cavity that will cause a local peritonitis. And that's the reason behind the pain that they have. At the same time, the free fluid is also there in the pouch of Douglas. So that can also contribute to the pain. Okay, so that's how you explain the pain factor. Further management, there is nothing to worry. So, but put her on analgesics as well as she can rest during this time. And also regarding the gallbladder, there is nothing to worry because it's just an incidental finding, but you have to give her the warning signs. Okay. So these are the things that should go through your mind during the 2 minutes time. So when you go inside, you can ask her whether she's in pain at the moment, any painkillers that she needs, okay? And you tell her, I've got the results of the scan with me. And sorry, let us go through this together, okay? So you draw the picture. So as I always tell you, picture is worth 1,000 words, okay? So you draw the female reproductive tract, the uterus, the tubes, and the ovaries. So you say this is a picture of the female reproductive tract. So we have the uterus here, 2 tubes attached to the uterus and ovaries, 1 on either side. So you say that during each period cycle, several follicles or small sacs develop in your ovaries, out of which 1 matures, which then breaks open to release the egg or the ovum. And this happens approximately around 14 days of your cycle. So if you undergo unprotected sex during this time, the ovum will get fertilized, resulting in pregnancy. So the scan shows that there is a follicle in your right ovary that has broke open to release the egg. Okay, so this is how you explain that. So also say that there is a small pouch called pouch of Douglas between your womb and the back passage. So it's between the uterus and the rectum. Okay. So say the scan shows some fluid in this pouch, which happens due to various reasons, and ovulation is one of the reasons, as some fluid that is released during this time due to rupture of the follicle can collect in this pouch. So coming to the appendix, you say that's a small finger-like tube attached to your large bowel towards the lower right side of your tummy. This is not visualized in the scan, okay? So that is when the role player will ask you, like my sister had a similar pain and it was appendicitis for her. So if you cannot see the appendix, how can you say that this is not appendicitis, okay? So we say that even if appendix is not visualized in the scan, as long as you do not have any other secondary inflammatory symptoms, such as fever, nausea, vomiting, constipation, or diarrhea, it's unlikely that you have appendicitis. So appendicitis is a clinical diagnosis rather than with investigations. So that's how you give the explanation for that. So you also say the gallbladder is a small sac that holds bile, a digestive juice secreted by your liver that is used to break down dietary fats. So the scan is showing 3 small stones of 1.5 millimeter in your gallbladder, which might have been formed from fats, calcium salts, and bile pigments. But the wall of the gallbladder is not showing any signs of infection or inflammation, as the wall thickness is normal. Okay, so this is how you explain the scan results. So say that the most probable reason behind the tummy pain that you have is an ovulation pain or a mid-cycle pain due to rupture of the mature follicle. So during this time, along with the egg, some fluid and blood will be discharged into your tummy cavity, which causes irritation of your tummy lining called peritoneum, and a local inflammation happens. Along with that, there is also some spasm of the tubes attached to your womb, and also fluid in the pouch of Douglas contributes to the pain. Okay, so local peritonitis plus a tubal spasm and also fluid in the pouch of Douglas are the reasons. Okay. So say that this is a self-limiting condition, nothing to worry about this. So it settles by its own. So you rest, take painkillers like Panadol. I can even give you a script for Panadine. So you can also place some warm compresses here. So give her the warning signs anytime that you think that the pain is becoming quite unbearable, any heavy vaginal bleed, report. So she'll ask you, what if this becomes recurrent? So if this becomes recurrent and disabling, you can put her on OC pills, okay? Because OC pills can stop the ovulation. So if there is no ovulation, there is no ovulation pain, okay? So regarding the gallstones, tell her no need to worry as you're not having any symptoms at the moment. But just in case you develop any upper abdominal pain, fever, vomiting, do report to the hospital to be seen by the specialist, okay? So I'll give you printouts regarding this, which you can go through. So this case for 8 minutes is you have to talk about the scan results and also the reason for the pain and also management. Okay. So you have to know this case well, because otherwise you cannot say all the points here. And as I told you, this was a 2024 case. So you have got a high probability of getting this this year. Okay. Any questions for Mittelschmidt that you have?
Can I ask you a question?
Yeah, sure.
If you were my examiner, you will pass me or no?
Naila.
Really, I want your feedback.
That's a difficult one to answer.
So I will not pass because I said something, but in
it's
general,
okay. But you said some of the good points.
yeah,
Naila. Okay.
I missed a lot, I know, but in general, like
yeah,
this.
In general, if I am the examiner, I'll let you through.
Oh, thank you. I hope you are my.
All right, because you came to the diagnosis and you told me, even though you said that you are not sure regarding further management, you said some good things. Okay. All right.
Thank you.
Okay. All right. Any other questions that you have for this case? That's a very difficult question to answer. But of course, I'll let you through. Okay. All right.
Thank you, doctor. I hope you are my examiner.
Okay. All right, dears. Any questions that you have regarding this case? No questions? Sure? Okay. All right. So always look at the last menstrual period. Okay. So if the periods are regular and it was like 2 weeks before, that means it's an ovulation pain. So similar case we have discussed earlier. What was that case?
Corpus luteal.
Corpus luteal cyst. It was a rupture of a corpus luteal cyst. Okay. This is another ovarian case that you can get, Mittelschmidt. Okay. All right. So 2 cases, I think. Oh, you also have another case. So regarding the ovaries. Okay. All right. So if you have no questions, shall we go for a break now? Okay. Yes. It's 3:30. I'll see you by 3:45. Okay. See you soon. Hi everyone, are you back? If you're back, please switch on your cameras. Someone back? Chrislyn will be the next one to do the cases.
Yes.
So can you switch on your cameras, please? The Alan is in the center, is it? So, yeah. All right. So, Chrislyn, you can do the next one. Okay. All right. So they have also asked you the differentials of fluid in the pouch of Douglas. Okay. So this also has been a question for you. So when you think about the differentials of the fluid in the pouch of Douglas, it can be ovulation, or it can be a ruptured ovarian cyst, PID, ruptured ectopic, a retrograde menstrual flow, could be a reactive fluid following appendicitis, or ascites because of cardiac failure, liver failure, cancers. Okay. So all these can cause like fluid in the pouch of Douglas. Okay. So Anna, Shibil, Unnimaya, if you're there, please switch on your cameras, please. Nehalka. Okay. Yeah. All right. So Chrislyn, this is your case. You can read through it. I'll time you 2 minutes. Okay. You can start, Chrislyn.
Hi, Lily. I'm Dr. Chrislyn. How may I help you today?
Well, look, doctor, I'm here to discuss with you my delivery plan. So, yeah, I have certain things in my mind when I go for this delivery. So I want my partner and kids with me during my delivery. Also, I would love to listen to some music. I just want the midwife to be with me, no doctors or nurses, and I want my afterbirth to be delivered naturally.
Okay. Yeah. All good. Thank you very much, Lily. I'll be asking you a few questions first before we can proceed to your delivery plan. But just to remind you that everything we talk will be confidential. Is that all right?
Thank you.
Okay. So congratulations, by the way. I would like to ask, is this your first pregnancy? No,
No,
I already have children. Sorry about that. So how was the previous pregnancy? So is it normal? Were there any complications?
the pregnancies all went well.
Mm-hmm. How many children, by the way, did you have before this?
I have 2 children.
2 children. So in both deliveries, were they normal vaginal or did you go through cesarean section?
No, it was all vaginal deliveries.
No complications or prolonged labor?
Yeah, I had the first delivery was by vacuum. And I lost around a liter of blood, and I had to be given a blood transfusion for that. So the second delivery, I had a difficulty with the placenta being delivered. So the cord got snapped, and I was shifted to the theater, and the placenta was removed. Okay, and then again, I had a blood transfusion at that time.
Okay, so no medications was given for you at that time.
Of course, medications were given.
So yeah. So did you recover quick after that, or did you don't have any fever after the recovery stage?
No.
Okay. Yeah. So how are the children? Are they developing normally?
Yeah, they're doing well. Thank you.
Okay, that's good. Are there no problems with your bowel or urination habits after that?
No.
Okay. So so I'd like to ask a few questions about your pregnancy now. So is the baby kicking normally? All good?
I just started feeling the baby kicks.
Okay, yeah. You did your dating scan?
Yes.
Okay. So yeah, okay. Did you do a Down screening test?
Yes.
Okay, so it was all normal.
Yeah, they didn't share any concerns.
Okay. Did you do another scan by this recently, 18 to 20 weeks?
Yes.
Okay, no abnormalities they mentioned?
No concern shared.
Okay, so the placenta is in this right position.
They didn't share any concerns.
Okay, yeah. Do you have any history, by the way, of high blood pressure in your previous pregnancies or in the family?
No.
Okay, yeah. Just a few personal questions. Do you drink alcohol or smoke?
No.
You don't use any recreational drugs as well?
No.
Eating well, sleeping well?
Yes.
Okay, no family history of birth defects?
Nothing that I know of.
Okay. Yeah. So, okay, thank you very much, Lily. So I'd like to address your concerns now regarding your planned delivery. So I noticed that you mentioned that you want first, so we are currently in a rural hospital, and I understand that you want to have just a normal delivery with a midwife. But considering that in your first and second pregnancy, there were a few complications. In the first pregnancy, you had a vacuum. So because of a prolonged labor. And the second one is you have a bleeding during the delivery of the placenta, so it snapped. So I know that you can have a safe delivery on your third pregnancy, but we will just want to make sure that everything will go smoothly. So I cannot reassure you that there will be no doctor during the hospital, and we will still have to monitor and observe you.
Doctor during the hospital? What do you mean?
I mean, there will be no, I cannot reassure you that there will be no doctor monitoring you during your delivery, because you mentioned you just want to have a midwife, right?
Yes.
So I cannot reassure you because we will still have to observe you in the next few trimesters. So we will have to see if you would be a high-risk pregnancy, because any time between second trimester and third trimester, there might be some complications along the way. So we will need to observe you. And it's if everything will still be low-risk pregnancy, then we can consider with just a midwife if you still prefer it. We will just have to observe you more. And regarding about having your partner and your kids during the delivery, we can have your partner there, but I'm not sure if the hospital, it depends on the hospital, if they will allow kids to be there during delivery, especially that it's a bit of a sensitive image for them to see at a young age. So, and then regarding soothing music, of course, you can have soothing music if you want to be relaxed during the whole ordeal, because it's very difficult, of course, giving birth. And then regarding the medical interventions, we can also not give you medications if you prefer to have just a natural delivery. But of course, like if anything can change, you can put it into planning. So we have like you can put it into writing, and then we can read through that once it is time for you to deliver. But you can change it anytime, as long as, of course, you are of sound mind and you're not in any way delirium or something like that. Hopefully not. So you can change it anytime. So there's no pressure if you want to change any of your plans during the delivery. Are there any other concerns that you would like me to address?
So I can deliver in this hospital, is it, doctor?
Yes, you can deliver in this hospital, but of course, like I mentioned, we have to check during the whole stage of pregnancy, during the third trimester, especially if you are still low risk. Because if you're at high risk, we might have to consider you transferring to a tertiary hospital where an obstetrician and also a neonatal intensive care unit is available, especially for the baby. Are you with me so far?
Mm-hmm.
Okay. So any other concerns that you would like me to address as well for your
Anything else that I need to know?
Yes, I would also like to just remind you a few of the red flags in case like you might have your water break for early on, like you have like if you feel like there's already fluid coming out. I'm sure you're already familiar with that. You must have to you have to go to the hospital straight away. And if you live outside of the hospital quite far, I suggest that you would have to we would have to admit you in case that happens, but hopefully not. But just remember that if you live quite far and we feel like you have a high risk pregnancy, we would advise you to at least live nearby, or at least a transportation that is easily accessible for you. Okay.
Anything else?
That would be all from my part. But of course, I will still have to mention this to my seniors as well and the consultants.
Okay, all right, Chrislyn. So, Chrislyn, when you read through this, what's the first question that comes to your mind? Like her concerns, when you read through the concerns, what's the first thing that comes to your mind? So, is it a home delivery that she wishes? Is it? Or a delivery in this hospital? Okay, so if she wants to have her partner and kids, if she wants to have a soothing music midwife alone, no interventions with the placenta delivery. So maybe it's a home delivery that she wishes, is it? So that's the first thing that you have to ask. Is it like a home delivery or a delivery in this hospital? Okay. And she'll tell you it's delivery in this hospital that she wants. Okay. And you have to look, you asked me whether this is a first pregnancy and all those. That was excellent. And you asked me for complications during pregnancy, the type of delivery, and also the complications at the time of delivery, which you caught. Okay. Then look always at the current state of pregnancy. So look for any bleeding, any abnormal discharge, any abdominal pain that she is having. Also look whether she had done all her blood tests, her blood group. Look for any incompatible blood groups. Okay. And also the rest you asked me, that was good. Then when you came to the counseling, and you can also look into her lifestyle, okay, support system and all those. So when you come into the counseling, do you think that she can deliver in this hospital if she has no complications in this pregnancy?
No complications in pregnancy. Yes.
No.
Mm.
Because she had two complications, like complicated deliveries before.
Mm.
Is it? And what can she have this time? Because this is her third delivery. What can happen this time?
Uterine inversion or rupture?
Not inversion, uterine atony, is it? So because of multiparity, a uterine atony can also happen. So she had interventions also before, like vacuum, delivery of the placenta. All this can result in a uterine atony this time, given that this is her third delivery. And there is a high risk she will bleed again. Okay, so you should not encourage her to have like a delivery in this hospital, because this is just a hospital which deals with low-risk pregnancies. So this is not a low-risk pregnancy. Actually, it is a high-risk pregnancy. Okay, because of the delivery complications and because of the risk of uterine atony that she has. Okay, so that was a major mistake or the error that you made. Okay. So when you came to partner and kids to be with her, you addressed that well. Okay. So like partner and kids, you told me kids, it is overwhelming for them to see the delivery. Soothing music. Can she hear music during the delivery?
I think so, but maybe during labor. But no, I mean,
she can hear it with the headphones, is it, without disturbing others. She can hear it through her headphones. But what about midwifery? No doctor, nurses.
I think it's not possible because
No. Yes. So it's always better to have the delivery under a supervision of the doctors and the nurses because of the high-risk deliveries that she had before, is it? So wants to deliver the placenta naturally with no interventions at all. What about this? That is what we usually look for, is it? We don't go for any interventions unless needed. So just because the placenta was retained the last time, it doesn't mean that it will get retained this time, is it? So normally we wait for the placenta to deliver naturally. So if it is not happening, that is when we do the interventions. Okay. So that is how you have to address this. Okay. But do you think that it is her choice by the end of the day?
it's a bit hard for Australia because sometimes like autonomy is very important here.
So it's by the end of the day, it is her choice where to deliver. Okay. But you have to make her aware of all the risks that can happen with this delivery, why it is better to deliver in a tertiary hospital with all the medical facilities that are available. And also, but if she wants to go ahead with the delivery here, then there are certain measures that you have to take from your side. Okay. So that is how you have to address her concerns and do the counseling. Okay, all right. But never encourage her to deliver in this hospital, okay, because of the previous complicated deliveries that she had. Okay. So this is a pure counseling case. Okay, so you have to know how to address each of it very well. Okay. So this case, I think it has not come last year, but it will definitely come this year. I'm quite sure they will ask you this year. Okay. So this again is a 2024 case. So I'll take you through this. So this is 27-year-old Lily, who is 20 weeks pregnant, coming to your rural hospital, which deals with low-risk pregnancies. So you're an HMO in the ops department. She's here to discuss regarding her delivery plan. So she wants her partner and kids to be with her during delivery. Also likes to have soothing music. Wants midwifery with no doctors or nurses. Wants placenta to deliver naturally with no interventions at all. So the first thing that you have to think about is, can she have this? So given that she wants her partner and kids to be with her, so that is a clue telling you that she might be having previous pregnancies and deliveries. Okay. So mark in your mind, you have to look whether she has to whether she had any previous pregnancies, any complications during her previous pregnancies, type of deliveries, complications at the time of deliveries. All these you have to assess. Okay. So coming to her concern, of course she can have the partner with her, but again, soothing music also she can hear through headphones. Wants midwifery with no doctors and nurses, means that if this is a low-risk pregnancy, it's enough to have a midwife. Okay. Wants placenta to deliver naturally with no intervention. So that is what we usually aim for. So we look whether the placenta is delivered naturally. But if she is having any bleeding or if the placenta is getting retained beyond a certain period of time, you have to intervene. Okay. So that's how your thinking should go during the 2 minutes. But the critical key point is whether this is her first pregnancy, whether she had complications during her previous pregnancies and deliveries. Okay. So when you go inside, ask her concerns, and she will tell you the concerns that she has. So always check whether it is a home delivery that she wishes to have. So she'll tell you she wants to deliver in this hospital, not a home delivery. So check on the current state of pregnancy because she's 20 weeks. Look for any vaginal bleed, abnormal discharge, any tummy pain that she has. And also look whether she had started feeling the baby kicks. Okay. And ask her whether this is her first pregnancy, and that is when she tells you it's her third one. So look for any complications during previous pregnancies. So she had no complications during the previous pregnancies. Type of deliveries is also important. So it's a vaginal delivery, all were vaginal deliveries. So look whether it was at the hospital or at home, and she will tell you it was at the hospital. So complications during deliveries. And that is when she tells you her first delivery was with vacuum because the labor was unduly prolonged. She lost 1 liter of blood afterwards. A blood transfusion was given. And the second delivery, the cord got snapped and she had a heavy bleeding. So she was shifted to the theater and the placenta was removed. Nearly died. Again, blood transfusion given. Okay. So when you come to all these, it's not a low-risk pregnancy that you're dealing with. Okay. So you also check on the last delivery, and it was like 2 years back. So you also look for any follow-up after deliveries, and are the other children doing well? Okay. So coming to this AN history, look for regular checks, the last check, any concerns. Has she done all her blood tests, her blood group? Down screening, scan at 20 weeks. So look whether it is a single baby, placental position, bowel bladder, quick lifestyle questions, diet, exercise, sad history. Is she up to date with all her vaccinations? Any other medical, surgical conditions, medications, allergies, and good support system. Okay. So, it's a pregnancy that falls under high risk because here again, at the time of delivery, she can have similar complications because of the multiparity, because of the instrumental deliveries that she had before. So there's a high chance that a uterine atony can happen, and she can have a heavy bleed or postpartum hemorrhage. Okay. So when you counsel her, tell her, I really appreciate your concerns. Even though your wishes sound wonderful, these might complicate your delivery, given the complications that you had during your previous deliveries. So the bleeding during earlier deliveries can recur this time, as this is your third one, and the uterus is already a bit lax. So it may have difficulty to shrink after the delivery. Given your circumstances, it is better to be cautious, as sometimes this can be life-threatening, and you may require blood transfusions as you had before to save your life. So apart from the heavy bleeding after delivery, other complications can also arise, like this labor can also become obstructed or delayed. You can get a retained placenta even. There'll be significant damage to the pelvic floor muscles and the uterus, and the baby can also have breathing difficulties or distress. Okay. So it's always safest to deliver in the tertiary hospital, as there are resources available and also trained health professionals like doctors to diagnose the complications and to provide support at the tertiary center. Here at this hospital, we deal with only low-risk pregnancies, and given the complications that you had during previous deliveries, this pregnancy of yours is a high-risk pregnancy. Okay, so this is how you explain. But coming to her concerns, so tell her your partner can be there with you at the hospital, but kids are not usually allowed, as it may be traumatizing for them to visualize labor. You can hear music with your headphones to relax yourself. And as this pregnancy is of high risk due to previous delivery complications, it is better to deliver under the guidance of the specialist rather than with the midwife alone. So unnecessary interventions will not be done in hospitals. Usually, if it is a normal delivery, they wait for the delivery of the placenta. which should happen around 15 to 20 minutes after the delivery of the baby. But just in case you have a heavy bleed, as during the previous deliveries, that is when interventions will be done to save your life. Okay. So that is how you express her address her concerns. Okay. So, but say that if wishing to proceed with the delivery at this hospital, do as much research as possible, as you should have sufficient knowledge to decide what is best for you and the baby. Analyze the risk-benefit ratio. But in my opinion, the risks will be outweighing the benefits. Okay. So we have to have a talk with the specialist, the maternal child health nurse, get their opinion, as they have to prepare an emergency management plan just in case you decide to proceed with delivery in this hospital. And also encourage you to attend the antenatal classes, but the final decision will be yours, and I'll do whatever I can to support your wishes and guide you through. You do not have to decide right now, as you have a lot more weeks to go, like another 20 weeks to go. But do think about all this before taking a decision. So I'll give you printouts regarding the complications that can happen at the time of delivery, and then you can decide by yourself. Okay. So this is a delivery plan counseling. Okay. All right. Any questions that you have for this case? So pure counseling station. Okay. Any questions? No questions? Okay. So are there any centers where they can deliver under the guidance of the midwife? Here in Australia? No one knows. It's called birthing centers. Okay. So birthing centers is more home-like than hospitals. So it's run by midwives. Okay. So they'll have their own room, in-suite bathroom. So can have people of her choice around her. And some centers even allow kids to be with you. Okay. And minimal medical intervention. So because it's just run by midwives, so no epidurals, only natural pain relief options, because epidurals has to be given by doctors. Okay. So if any complications, they will transfer her immediately to the hospital. But the problem is they also take only low risk pregnancies, and birth expected to be straightforward. So birthing centers is also not a choice in this woman, okay, because of the previous delivery complications that she had. So I just put in this just in case they ask you any questions regarding this, okay. So this is what we call as birthing centers, okay. All right. Any questions? So it's usually nearby the tertiary hospital, okay. No questions? No? All good? Okay. So if you have no questions, then we'll move on to the next one. So I think we'll be doing the next. Saurav.
Yeah, that's right.
This is your case, Saurav. Read through it. I'll show you the picture, okay? Shall I give you the picture, Cedric? Okay. So we can start.
Hi, Amanda. I'm sorry, one of the doctors here today. How can I help you?
Look, doctor, it's about my arm. So it's a bit swollen. So I just want to know why this has been happening.
Okay. Since when have you been noticing this swelling?
It has been there since the last, say, around 3 months.
Yeah. Okay. Before starting, I'm really sorry to know this. How are you coping with this surgery? How are you dealing with this? Are you okay?
Yeah.
That's fine. So you've been noticing this swelling since 3 months?
Yes.
Okay. Do you have any pain?
No, but it feels a bit heavy.
Okay. Swelling in the arms, right?
Yeah.
Okay. So, and it's heavy. Do you feel any sensation of tightness within the arms?
Yes.
Any numbness?
No.
Any tingling sensation?
Anything?
Tingling sensation? Tingling?
No. No.
Well, have you noticed any skin changes before and after now?
Nothing that I can see.
No, anyway.
Sorry.
No, yes?
No.
Have you noticed any raised temperature over the arm? Is it warm to touch?
Nothing that I can feel. I haven't specifically checked for it, but nothing that I can feel.
Okay. Any restricted shoulder movement?
Yeah, I can. It's a bit hard to move my joints.
Okay. Since when have you noticed this difficulty moving joints?
Since the swelling happened.
Okay. So is this been limiting your daily activities?
Yes.
Really sorry to hear this now. So tell me more about the pain. Is the pain present all the day or it's worse at the night?
There is no pain, doctor. It's just a heaviness.
So, okay, is the heaviness all the time you've been noticing, or at the end of the day, is there any sort of time that it gets?
No, it's there always.
Okay. So have you tried anything to reduce the tingling sensation by raising the arms? Like that, have you
I
tried?
have tinkling, doctor.
Okay. Get that tingling sensation. Okay. Have you noticed any lumps around the axilla or in the chest wall? Any new
No.
lumps you've noticed? No.
No.
Any changes in the opposite breast? The breast that is normal?
No.
No. Any pain in the joints, especially in the bony part? Are there any tenderness in your whole body?
Tenderness, what do you mean?
In that is pain. Any specific pain?
I don't have pain, doctor.
Okay. Have you noticed any weight loss?
No.
Have you noticed any? Are you fatigued then after the surgery?
Yeah, I was a bit tired after the surgery, but then I recovered.
Okay. Do you have any cough?
No cough.
Any shortness of breath?
No.
Okay. Any headaches you've noticed?
No.
So I would like to know more about your past history. So what was the staging of your surgery that you went for? Do you have any idea regarding this?
Yeah, it was stage 2.
Stage 2, okay. You only had radiation therapy, right?
Yes.
Did you undergo any chemo or anything sort of like that? Doctor mentioned anything?
No chemo.
Okay, no chemo. Did you have any radiotherapy complications like that?
No.
Okay. So do you have any concerns regarding your body posture now?
Yeah, it's body posture. What do you mean?
Yeah, like it's uneven, feeling awkward in going to the people surrounding, like that feeling.
Nothing like that.
Okay, how's your mood?
Mood is okay.
How's your home situation? Are family members well supportive?
Yes. So your time is up for the history.
I would like to continue with the questions. Do you have any fevers?
No, you can't because it's only for 4 minutes, Saurav. So they won't allow you to proceed beyond that. Okay.
Okay.
But no fever. Yeah.
Okay. So I'm up to the other tasks now.
Yes.
Okay, thank you, Amanda, for providing me the history. So, Amanda, you've been through all the major treatment. It's completely understandable to have concerns. So let us discuss it together. Mm, yeah, because you had the axillary clearance and radiotherapy, it can occur. I'm lost now. What should I say? So as you are having heaviness and tightness and swelling, you need to avoid the trauma and injections and injections. And also you have to avoid taking blood pressure on that specific arm, and you need to apply the moisturizer cream. And also you need to avoid the burns and cuts, especially in that area where you are having swelling. And also, if possible, you need to do the gentle exercise like physiotherapy in order to reduce the swelling and to promote the movement of the affected arms. And also, if possible, are you happy with your weight? Have you gained weight then after?
No.
Okay. So also, apart from that, you need also to cut down with your weight if you are feeling you are gaining weight. And also, compression sleeves, compression sleeves can be put on to prevent further swelling of the arms. Because the stiffness that you are having, it might be because of the fibrosis that might have occurred after the radiotherapy. Uh, yeah, and for that, you will have to do regular physiotherapy and regular range of motion exercises. Oh. And also, breast examination is to be done every 6 to 12 months. Also, annual mammogram is to be done of the opposite breast. And you need to report if you notice any new lumps, any bony pain, any persistent cough, weight loss, and any neurological symptoms that appears, you need to immediately come to the hospital. Yeah, if anything happens in between, then you need to rush to the hospital, come to me. And that's it, I can say.
So what am I having, doctor?
Most probably radiation therapy side effects and everything you're having, because this is a post-mastectomy issues that usually occurs when the lymph nodes could not drain properly, as there's a clearance of your all lymph nodes, and the everything that comes and gets accumulated within your arms. So that is the reason why you are having swelling. Yeah, so this is the post-mastectomy effect, I can say. I'm not sure.
All right, so you couldn't say the diagnosis, is it? All right, coming to the history was sort of okay, Saurav, okay. But always check whether it was a sudden onset or a gradual onset. Is it worsening? Okay, so all these you can check on. And you asked me for numbness, weakness, trouble, movement, all those you covered. So you also look for any treatment that she had taken so far for this swelling. Okay. So I could see that you were thinking about weight loss, lumps or bumps around the body. But did you check that whether I'm having regular reviews with my specialist? Did you look when my last mammogram was? Okay, so all these are important. Okay. And also you have to look for other cancer screens also, because already she has one cancer. So you look whether she is up to date with other cancer screens. Okay. Menopause also you can touch on any problems of menopause that she is having. Sexual history also you can touch on. Okay. So her lifestyle is important. But she might be having some medications that she is taking, is that? So always check for any other medications that she's on, and she's on tamoxifen here. Okay. So all these are important when it comes to the history. When you come to the counseling, you have to say the diagnosis. So what is the diagnosis here? What do you call this? Anyone?
Lymphedema.
It's called lymphedema of the left arm, is it? So he told me all the reasons behind lymphedema. That was good. Okay. So he told me it's because of the everything collecting in the arm. That is what you said. It's not like everything collecting in the arm, but it's a lymph that is collecting in the arm. Okay. All right. So again, it can cause one is a mastectomy with the axillary lymph node clearance, and the other is radiotherapy that can result in this. Okay. So when you came to the counseling, management, here we have lymphedema clinics, Saurav, whom you can refer her to. Okay. So there'll be specialists there, there'll be physios who are trained in treating this lymphedema. Okay. So you have to refer her to the lymphedema treatment specialist clinic for a clinical assessment. Okay. So you told me about physio, that was good. But again, massages, compression sleeve, you told me. And also, whenever possible, ask her to keep that arm elevated above the level of her heart. Okay. And you told me some of the precautions to be taken as well. That was good. Okay. So precautions. The management, I didn't have a bit of only that referral was missing. Okay. Otherwise, you tried to address the management well, but you have to know the diagnosis that this is lymphedema. And also in the history, you have to make sure that she has regular reviews with the specialist. She's also doing her mammogram regularly. You told me that when you came to the management that I have to do an annual mammogram for the other breast. Okay. But now you have to look for all this, is it? So regular reviews by the specialist, last mammogram. Okay. Right. Yeah. So I tried to do the case well, Saurav. Okay. All right. It was okay. So only that term was missing, like lymphedema. Okay. All right. So I'll take you through this. So this is 58-year-old Amanda at your GP. So her picture is given. She has no signs of inflammation at present. Okay. So the picture looks like this. And, there is a swelling of the left arm. So it's written she was diagnosed with left breast cancer, for which a total mastectomy with left axillary lymph node clearance was performed 14 months, followed by radio. Okay. So, this invariably a lymphedema that is happening because of the mastectomy with axillary lymph node clearance and because of the radiotherapy. But again, what are the other possibilities of this swelling that you can think about? Anyone?
Recurrence of cancer.
Recurrence of cancer. Then?
Maybe axillary DVT.
Then?
And maybe insect-white cellulitis.
Cellulitis. So these are the differentials that you have to think about. But again, it's written that there is no signs of inflammation at present. Okay. So that means it's not unlikely to be a cellulitis or axillary DVT. So just think about lymphedema, recurrence of cancer, very, very important. Okay. So cellulitis due to trauma, insect bites, axillary DVT, where she has no signs of inflammation. It's not going to be cellulitis or axillary DVT, but you have to think about lymphedema, recurrence of cancers. So when you take a history, look whether it is a sudden or gradual onset. Is it worsening? And look whether it is affecting her activities of daily living. So you also look whether she had got trouble bending or moving the joints, any associated numbness or weakness of the arm. Okay. So how can numbness and weakness of the arm happen? How can that happen? Because of the traction, is it? So the arm will be like overweight and there'll be a traction on the nerves from the neck, and that can result in numbness and weakness of the arm. Okay. So you look whether it is happening as a generalized edema. So you look for swelling of any other part of the body, any treatment so far. Okay. So when you come to the differentials, it's mainly the cancer that you have to rule out, recurrence. So look for any weight loss, lumps or bumps, or any skin changes that she had noticed. Is she having regular reviews with her specialist? Last review, any concern shared by the specialist. Also look, when was the last time that she had her mammogram? And just a quick look into her bowel, bladder, other cancer screens. So CST, bowel cancer screen. Just touch on the menopause, the age, any symptoms of menopause, lifestyle, diet, exercise, and a sad history. But because she's a cancer patient, always a cancer survivor, always make sure that you ask for a good support system. Other medical surgical conditions, any medications. And here she's taking tamoxifen. Okay. Also look for allergies, family history of breast cancer. So this is how the history should go. So when you come to the diagnosis, tell her that what you suspect in her is a condition called lymphedema. So you say this is because of the collection of lymph. So your body, in our body, we have two systems, like a circulatory system through which the blood flows and the lymphatic system through which the lymph flows. Okay. So you say that the lymph is a clear colorless fluid in the lymphatic system of your body, which removes waste products from each body region. And it also helps to fight against infections. Okay. And the lymphedema happens because of the collection of this lymph. So you say that during breast cancer surgery, the lymph nodes from your axilla has been, or your armpit has been removed. And as these lymph nodes drain lymph from that arm, the lymph starts collecting in the arm, resulting in swelling of the arm or lymphedema. Another reason is the radiotherapy, as it closes the channels, further blocking the drainage. So you say that this cannot, unfortunately, we cannot cure this condition, but it can effectively be managed. Okay. So when you come to management, refer her to the lymphedema specialist clinic for further assessment. So you say that the specialist will see you. There are also physios who are trained in dealing with lymphedema. So they will teach you exercises specific to improve the lymph drainage. Also massages to move the fluid out of the swollen area. So from my side, I'll give you a prescription of a compression sleeve, which you can get from the pharmacy, and make sure that you elevate the arm above the level of your heart whenever possible. And also make sure that you don't gain weight, because weight gain again can make it worse. Okay. So maintain the weight within the desired limit. Okay. But your management doesn't end there, because once she has lymphedema, this arm is always at a risk of infection. Okay. So you tell her the precautions to be taken. So you ask her to avoid taking injections, blood pressure measurements from that arm, avoid carrying weight with that arm, be cautious against cuts and wounds, wear gloves during housework. So in order to avoid all these cuts and wounds and burns, no hot or cold packs. Why? Why?
Ma'am, because the cold and cold packs are for decreasing the inflammation or the swelling when there is the vessels are involved, the blood vessels are involved. And this one is the lymph. Maybe this is it.
No, Manish. It's
Right?
mainly because of burns. Okay. Risk of burns. So hot burns are there, cold burns are there. Okay. So she can get burns on that part, which again can get infected. Okay. So also ask her to take good care of her nails and skin. Keep the skin well moisturized, but give her the warning signs. Anytime she notes any redness, if she has any pain, warmth, fever, ask her to come back. Okay. Give her all the printouts regarding lymphedema, which she can go through, and offer to see her in a month time. Okay. So this is lymphedema. Very common case that came this year. So it has come twice this year. Okay. All right. Any questions that you have?
Doctor.
They always look whether you are ruling out the recurrence of cancer. Okay. So that's very important in this case. Yeah.
Doctor,
Because,
will there be any pain in the lymphedema?
sorry?
Will there be any pain in lymphedema or
No,
normal?
usually a heaviness feeling, no pain.
No pain.
Unless it is infected.
Yeah, but in TVT there will be pain, right? So then
There will be
differentiate
pain. Yes.
from
Pain, redness, warmth, all these will be there in DVT. Yeah.
So, doctor, in case of bilateral mastectomy is done and there is lymphedema on both sides, then what about the injections and blood pressure measurement for that case? We will give the precaution to that patient.
Yeah, of course, you have to. But the thing is, you cannot avoid taking blood pressure measurements, is it? So injections also, you can choose any other site for injections if she has bilateral lymphedema. Okay, so you can give it over the like buttocks and all those, is it?
Yeah. Thank you.
Yeah. Any other questions? No? All good with lymphedema? Okay. So if we have no questions, we'll move on to the next one.
Doctor, what will be the critical error for this station?
There is no critical errors now, Divya. Okay, so they don't look for critical errors, but they look for key points and critical key points. Okay. So there are no critical errors nowadays.
Oh, thank you.
Doctor, when we're taking a history from the patients and talking about like any history, for example, this one, we'll talk about first the critical points history first and then the other history, or we can take in any order.
No, you have to start with the presenting complaints.
Yeah.
So then if it is a gynecology, look for associated symptoms. When you come to associated symptoms, you focus on the differentials, okay? And ask the associated symptoms accordingly. If it is a gynecological history, go for the period history and a sexual history. And also, if you have some other questions regarding the differentials, you focus on that. Then other medical surgical conditions, a quick look into her lifestyle as well. So in each of these, there'll be, in some cases, for some cases, there'll be critical key points which you need to cover. Okay. So you cannot say like ask critical key points alone in the beginning. No. Okay.
Okay. Thank you.
Any other questions? No? Okay. So we'll be doing the next one. Unimaya. Okay.
Yeah.
Anna, how are you? Are you feeling okay?
I'm not doing the best, but hopefully better tomorrow.
Okay. You're having cough and cold?
Yeah.
Okay. Get well soon, okay?
Thank you.
So, Maya, I'll give you the case. This is your case, Maya. Read through it. I'll time you 2 minutes, okay? Maya, you can start.
Okay. Hi, Olivia. I'm Unimaya, one of the GP here today.
I know you, doctor.
Okay. Okay. How can I help you, Olivia?
I just came to collect the results of my scan.
Okay. So we have done your ultrasound scan, and I have gone through your history last time, and we have. I will explain you the results. Okay. So before starting the consultation, do you have any other special concerns should I address today?
No, just why these symptoms are there and what is the scan result.
Mhm. Okay. Do you have anyone to be with you to
Why, doctor?
while discussing the result?
Why?
Okay. So okay. Then I will. Okay. We have done a transvaginal ultrasound. Okay. It's a ultrasound scan done through your vagina. It showed that a 12 centimeter right ovarian mass in your ovary. There is a 12 centimeter size mass. It showed the features of it is solid and have cystic areas. That means some fluid like substance are collecting in it. And the ultrasound showed that it has increased vascularity, means there are so many blood vessels are there. So I'm worried about that. It is the possibility of a ovarian cancer. Are you with me so far?
Yes.
I understand this is a tough time, and you have your symptoms like bloating and history of constipation and loss of appetite, and you have weight loss and history of a strong family history of bowel cancer and other breast cancers in your family. And so it is not this raises me concerned about having a ovarian cancer. So do you want me to proceed, or should we have another consultation to discuss this about?
Just tell me, doctor.
Okay, so it is not confirmatory yet. I will refer you to a gynecologist to further investigations, like we have to take a biopsy and we'll go for a surgery.
We'll go for what?
Surgery. They may do, and the specialist may decide what is good for this, and we will do some tests like BRCA gene analysis, and we may do CA-125 to diagnose it. And
Finished?
do you have any other concerns should I address?
Anything else that I need to know, doctor?
Mm, we can also do a
Have 3 minutes left. Anything else? Did you read your task?
probable diagnosis, correlate examination, and ultrasound findings.
Which did you miss? Anything that you missed? Did you tell me the examination findings at all? What's the examination finding?
Right adnexal fullness.
So you have
Right.
to correlate examination and ultrasound findings, is it? So first you say the examination findings, then you explain to her the ultrasound findings, is it? And ultrasound, you told me there's a 12 centimeter ovarian mass, solid cystic areas, but you didn't mention about the next one at all. What is that? Cystic areas with?
Papillary exercise.
Do you know what that is?
No.
No. So that's why you skipped it, isn't it? I knew it. Yeah, you'll skip it. Okay. All right. So what are papillary excrescences, anyone?
It's a finger-like projection.
Sorry?
It's a finger-like projection.
From where?
In the present in the ovarian lining. From the ovarian lining, it's a finger-like projection, I think.
So what does that mean?
Cancer, most probably.
Most probably it's 99.5% ovarian cancer. So that's the significance of papillary excrescences. Okay. So you have to say all those. Doppler ultrasound, increased vascularity. So you say an increased blood supply to that tumor. That's how you explain that. Okay. But again, there are a lot of risk factors for ovarian cancer in her. What are the risk factors, Maya, that you can
She is
identify?
nulliparous and obese.
How does nulliparity contribute to ovarian cancer?
Because of increased number of ovulation.
What? Yeah, you came near. So in nulliparity, there is no break in the ovulation because of the pregnancy, sir. So the more the ovulation, that becomes a risk factor for ovarian cancer. Yes, then?
I have BMI is high, 28.
How does increased BMI become a risk factor for ovarian cancer? Anyone?
And the estrogen is produced from the fat cells that
Yes, it's because of the increased estrogenic production from the adipose tissue. Okay, so that again can predispose to ovarian cancer. Any other risk factors?
Family history of cancers.
Family history. I'm asking Maya. Let Maya answer. Okay, she has to think about this case. Yes. Which cancer is important?
Breast cancer in her.
Why?
Like BRCA gene.
Excellent. BRCA1, BRCA2 gene mutations. Yes. Any other risk factors? Anyone?
Advanced age.
Age, advanced age. Okay, so all these are risk factors in this case. Okay, So all these risk factors also you have to say, and then only say break the bad news. Okay, so don't say that you are having ovarian cancer in the beginning, like, do you want someone to be with you? So invariably she'll ask you the question, why? Okay, so what's the reason why you want someone to be with me? So first you say the breaking bad news to her, and then you ask her, do you want someone to be with you during this time? And you say all the counseling sentences. Okay. All right. So that is how you have to analyze a case, is it? So explain to the patient the probable diagnosis. So highly likely that this is an ovarian cancer, but don't say it as in a confirmatory way. Okay. So you can confirm it only by doing biopsy and also any other investigations?
Tumor markers.
Tumor marker, CA125. Okay, so all this has to be done. Okay, so then only you can say for sure this is an ovarian cancer. Okay, this again a purely counseling case. Okay, so ovarian cancer came twice this year, but there was no scenario that was written there. So I don't know whether it is the same scenario that they have come up or they have given you some other scenario. Okay, but twice ovarian cancer was given this year. Okay. So I'll take you through this. So this is 65-year-old Olivia, next patient at your GP, complaining of bloating of her tummy around 6 months. She also has prolonged history of constipation, loss of appetite, significant weight loss. So till here, what will you think about?
Bowel cancer.
Any cancers that you'll think about?
Bowel.
Bowel cancer. But what tells you it's not a bowel cancer? She's up to date with all the cancer screens. So that means she has done her bowel cancer screening, her cervical cancer screening, mammogram. So all these has been done. So that is what is ruling out a bowel cancer. Okay. And she has no shortness of breath or jaundice. Okay. So keep it there. So she's nulliparous, her BMI is 28, so she's overweight. She has a strong family history of bowel cancer in her dad and brother, cancer breast in her sister, and all are doing well now. So when you did a pelvic exam, it's showing a right adnexal fullness. So you had ordered a transvaginal ultrasound, which showed a 12 centimeter right ovarian mass with solid cystic areas with papillary excrescences. A Doppler ultrasound done showed increased vascularity. So given the risk factors, given the non-specific symptoms that she is having, and also examination showing a right adnexal fullness, transvaginal ultrasound showing a huge mass in the right ovary, a complex mass with papillary excrescences, increased vascularity, highly likely that this is an ovarian cancer that you're dealing with. Okay. So when you come to the task, you have to correlate the examination ultrasound findings and explain to the patient the probable diagnosis. Okay. So when you go inside, ask her how she is feeling at the moment. Are the symptoms pretty much the same? Okay. And then you draw the picture of the female reproductive tract, so the uterus, tubes, and ovaries. So you say that you have been experiencing abdominal discomfort, including a sense of bloating, changes in your bowel habits, along with more generalized symptoms like a loss of appetite, unintentional weight loss. So all these symptoms are non-specific symptoms. And during the internal vaginal exam, I was able to feel a fullness and a lump on your right side corresponding to your right ovary. So your ultrasound scan showing a 12 centimeter mass in your right ovary. The mass contains both solid tissue and cystic fluid-filled areas with finger-like solid projections arising from the ovarian lining. So this tumor also demonstrates an increased blood flow on imaging. Okay. So when we consider all of your symptoms together, along with other risk factors such as your age, your increased weight, not having any pregnancies at all, family history of breast bowel cancer, the overall picture is concerning. And I'm very sorry to tell you that these findings strongly suggest the possibility of a cancer in your right ovary. Okay, so that's how you say. So now we tell her, I understand how difficult this news must be. It's completely natural to get overwhelmed. Is there someone with you today? Or do you like me to call someone to be here with you? Having support around you is important, and you have to feel support. You should have enough support from your family and friends at the moment. Okay. So say, I know this situation has been very distressing, and I'm sorry that you're going through it. It's reassuring that you're not experiencing any shortness of breath or jaundice, which makes spread to the lungs or liver less likely. So that means there is no metastasis. Okay. So to make sure that you receive the most appropriate care, I'll organize a multidisciplinary team of health professionals based on your needs and preferences. I'll also arrange further investigations, including tumor marker tests and referrals to the specialist, so we can confirm this diagnosis and plan the next steps. Okay. So organizations such as Ovarian Cancer Australia and the Cancer Council, they have trained cancer nurses who can explain what you can expect during this treatment, discuss the effects of cancer, and also they will connect you to support groups and community services. I'll also provide you printed information with their contact details, along with the resources available about ovarian cancer. And please remember that you're not facing this alone. We'll all be there as a team to support you at every stage of your care. Okay. So this is how you do the ovarian cancer case. Okay. So this again a pure counseling case. So all these are counseling stations that you get. Okay. Any questions that you have? Any questions?
Doctor, I have a question.
Yeah.
One of my friends, she had the exam and she told about this kind of question, counseling question. And she was saying that the patient started crying and when he heard the news, and she didn't know how to, she gave her the tissues and water, offered water. But because she was saying I was running out of time and I have to speak, but the patient was just crying and crying, and that's the scenario was there. So I'm just
That's
asking.
because
Yeah.
she didn't say the counseling sentence as well, Mahvish. That's why they keep on crying. Okay. So ask them if they want some time to compose themselves before you continue with the consult. Okay. So say all these counseling sentences, so then they will settle down. Okay. So tell them they are not alone. So we are all there to support them as a team at every stage. Okay.
Yeah. Okay. Thank you.
Yeah. Any other questions? No. So we have done a lot of counseling cases today. Okay. So all these are gynecological and obstetrical counseling cases that you get for the exam. Okay. All right. So if you have no questions, let us wind up for today because it's 5. So I'll see you tomorrow with the rest of the obstetrics and gynecology cases. And yeah, we'll see tomorrow anyways. Okay. All right, dears. So have a good evening. Take care. Stay safe. My slides are up to date. Am I right? Have you checked your portal?
Yes.
Yeah. So it's all up to date, both gynae and psych, is it? Okay. All right. So all of you take care. Stay safe. It is winter. Take care of your health. Okay. So stay positive. Stay happy. I'll see you tomorrow morning. Okay.
Thank you, Doc.
Yeah. Yeah. Bye-bye, dears. Bye-bye, dears. Bye.